All right, good afternoon, everyone. We're going to get started. What a fantastic morning session we've had so far. So, with me are my colleagues and friends Ryan Law, Doug Rex, Colin Noel, Mohamed Gabber, and Alan Barkin. We're going to go to room 15, where Dr. Messman and Dr. Bilal have been working diligently on that rectal lesion. Helmut and Bilal, can you hear me? We can't hear you as yet.
Yeah. I'm still struggling.
Helmut.
Can you hear us?
Yeah, we can hear you. This is looking beautiful.
So I thought I'm faster, but we have problem. I show you this not cutting. Go to spray. Go to spray. Okay.
So we have traction on now.
I show you in a minute what we did, because there is severe fibrosis, maybe to the tattooing as well. I was not able to open up here, so we did different techniques. At the end, yeah, you see, I go back. We had already cut the other side, and now here is a severe fibrosis, which makes me really struggling. And now with a clip line from Microtech, you see here, I could fix it on the opposite. I have now a traction. I tried to avoid it because I had this nice gravity, but this was not enough because of this here severe fibrosis. But now it's yeah, sometimes.
Can you hear us, Sachin?
And then let's go to 16. Show, and then we go to
Can you see the
Ecuador.
proximity people on here? Michael, can you see where proximity is? I don't know if they can hear us. Or we can hear them and see what's happening. Can they hear us? Sachin, can you hear us?
You're going to go to room 16 next, and you're going to be presenting this case. That
Injection
Benola is
again?
going to
Sachin,
do
can you hear us?
underwater.
Thank you. Thank you. It looks good. Yeah. This is good. This is good. Oh no, good. Thank you.
Sachin, can you hear us?
And
Yeah, we can hear you, Bill.
Oh, okay, perfect.
Injection.
So we had to switch strategies
Injection.
from the pocket and tunnel method to go to
Stop.
traction because of severe submucosal fibrosis on one of the mucosal edges.
Yeah. Is this ever left? Yeah. Yeah.
So it's kind
I think
of
we're gonna, Bilal, we're gonna move to room
Good.
16 and introduce
sounds
that
good. We'll keep
case.
hacking at it. Thank you.
Good work.
Okay. Stop.
can we get the case presentation, please, for room 16? That's case number 12.
So case number 12 is a 77-year-old male with a history of coronary artery disease. Status was cabbage, peripheral artery disease, and infrarenal AAA on aspirin and Xarelto. Found to have multiple colon polyps greater than 10 millimeters in size, including a cecal and hepatic flexure polyp measuring 30 millimeters in size. Resection of the two larger polyps was deferred in the prior colonoscopy. Biopsies of the lesion were consistent with tubular adenoma without high-grade dysplasia. A tattoo was placed near the hepatic flexure polyp. There's images of the representative polyps. Plan for today is colonoscopy with endoscopic mucosal resection with Dr. Binmoller.
Good afternoon. So the plan is actually to start with water exchange colonoscopy. I'd like to demonstrate that.
We can't hear you yet, Ken.
Ken, are you able to hear us? We can't hear you.
I can hear you, so I'll wait till you have the audio. Tell me when. Testing. machine. Tell me when you have the audio.
Ken, if you can just show us the polyps and show us kind of what we're working with, then we are going to quickly go to Ecuador and then come back to you.
Can you hear me at all? No?
We're not quite ready to go to Ecuador. Can we go back to room 16, please?
So he's moving underwater immersion, presumably, the data he showed at lunchtime.
Mal puesto ese.
Can you hear him?
He's doing the colonoscopy on the water.
Yes.
Okay. Could you please start over?
For those of you who didn't see, water immersion actually increases the likelihood of getting into the cecum. There's some good data to show that. Yeah, now we can hear you.
Yeah, perfect. We're going to need you to repeat everything you said, Ken. No, I'm just kidding. Please don't. Please don't.
Hi, everyone. Can you hear me? Hello. Can you hear me? ¿Puedo tener el retorno acá? Porque no los escucho a ellos.
Telling. If you see these.
We can hear you on Zoom, but it looks like they can't hear you in the room. Please stand by.
So, hi. Can you hear me? Can you hear me? No, no, ¿me puedes hablar, preguntar?
Ken, can I ask you, are you filling the colon with water or saline?
Saline. Now, when you start seeing debris like this, then you know you're getting into the right colon. So I guess you still are with me. They told me that we're switching to Ecuador. So here I've got some debris, right? In fact, this patient did not get the memo about stopping seeds. So you see there's a bunch of seeds here. So this is the other reason why I like underwater, because I want to clean out all of this debris, water exchange, I should say, all of this debris when I do my resection. And let's just say you have a perforation. We talked about that. And yes, it could be that some of that water gets into the extramural space, into the peritoneum. But if it's clean, sterile water, I think that's less of an issue. It's more of an issue if it's dirty water. So I think it's worth taking the time to clean it. Go ahead.
As you clean that right colon and kind of get it prepared to show us the lesion and start, we're going to switch to Ecuador and come back to you.
Hi.
Ken, we can still hear you. All right. Hey, Carlos, it's Sachin. How are you?
Hey, Sachin, how are you? Good to hear you.
Fantastic.
I just
Nice to see you, my friend.
Just see you in the videos, in live lectures, but never, just few times a year. Okay,
I
I'm
know,
very
I know.
happy to
We
see
need to
you.
get together. But you're live, Carlos, and love to hear what you have and what you're going to demonstrate.
Yes. So I will pass the case. ¿Me pueden mostrar la imagen para leer el caso, por favor? El PowerPoint. So this is a 15 years old female with recurrent upper abdominal pain and fullness. So laboratory blood tests were normal, and the CT scan showed a pancreatic cystic lesion. The procedure for today is US evaluation of pancreatic lesion. Okay. So now I am doing a US. Today I'm using a Pentax scope. This is the J10 UT series. So I have this lesion here. You can see in the B mode. I am trying to get some time because I know that you are delayed. But this is the mass here. We can see very well. Okay. So one of the things when I see a pancreatic lesion or a mass that is described by the CT scan is first I want to see if it was described as cystic lesion, but this is not. This is a I believe this is a solid cystic lesion, to be honest. We have some areas of necrosis here inside. And when we have this, one of the things I want to see also is how is the main pancreatic duct and how is the other part of the pancreas. So I can see here a little bit, you see, very well. So the main pancreatic duct is perfect. So there is no issue there. So it's no dilation. So I believe this lesion, probably because of the age of the patient, because of the gender of the patient, I believe this lesion is a pseudopapillary tumor. Is one of the things that we need to think about that. So second, I will use technology, right? This is my way to work. So I really love technology. I don't know why, a lot. But I try to correlate everything that I see in my lesions. You can see here. So this is a mixed lesion, right? So it's a solid lesion. It described as at least by software, we have blue areas that could be a hard tissue, but sometimes it is not enough. It means this technology showed, to be honest, this showed by the grayscale. The colors are you looking is because of the grayscale scale and not a real elastography. But nowadays, we have other technology called it shear wave, and you can see when I make the difference between A and B, it means between the solid lesion, it means the blue lesions as compared with the red area that I always take the mucosa because it's always the same. So I don't have different results in terms of what I have is 6.97. It means it is normal is until 5. So there is a lesion, but it's not a rigid lesion in spite that we see blue. And now we have something that is much interesting that is shear wave is to measure in an objective wave in kilopascal the elasticity of the lesion. So this lesion have in mean 2.9. It means it's not a really solid lesion. It's not a hard tissue. So once I did everything, so now I know that this is not like a hard tissue. So probably my differential diagnosis is to evaluate how this lesion, can be diagnosed. I know by BMO that it is not dilation of the main pancreatic duct. This is a young woman, and one of the big things that I have to think about is in this pseudopapillary tumor. So one of the characteristics is the contrast enhancement is normally is a peripheric contrast enhancement, and that is very interesting because it helps us a lot, when we send to the pathologist the information and also when we talk with the patient. But also nowadays we have a technology that will replace the contrast, call it DF5. So the thing is, we can see the microvascularization with this technology, and I can see that there is vessels in the peripheric area. You can see here but inside the tumor is not. You see? So there is not a hyper concentration or hypervascularization. So I will try first to use contrast. Are we ready with contrast? Okay, so I will start with contrast. Sí, la mitad primero.
Carlos, this is Ryan. A quick question. Can you talk to the audience a little bit about how using shear wave and elastography and now DFI helps guide where you're going to take your biopsies?
Yes. So to be honest, elastography it was one of the main. Okay, so we pass the contrast. I will explain that very quickly, but I need to be clear here because we have few seconds. So we have 27 seconds, and now the contrast needs to appear. You see, it's arriving here. Contrast. We see contrast here, but the lesion, you know, is not like performing a hyper contrast enhancement. You see, this is hyper, real here. But inside the lesion, no. So we have similar results as we have with DFI. It means this lesion doesn't have, any vascularization inside. So pancreatic adenocarcinoma is one of the characteristic of them is that they don't have hypervascularization, but pseudopapillary tumor is also. They didn't have hypervascularization inside. So as per my elastography, as per my shear wave, and as per my contrast now, and also because of my DFI, I know that this lesion is a pseudopapillary tumor. Okay, so now we need to take a biopsy, okay, from here, because pathologists always need that, right? Tissue is the issue, right? And probably the concept of tissue is the issue will change in the future just by video endoscopy. Huh? This is something that is very interesting. So I will explain to you. Elastography is this one, this technology. Give me 1 second. So I don't know why. Well, it's just to put a button you see here, and then we make the software may perform the color just by software, but we are looking the grayscale. So the red areas are soft as the software is showing you, and the blue areas are hard, but we have mixed areas here, green and blue, you see? So it means that this lesion, and because of the number of the elastography, the quantitative way that we are taking comparing A and B zones, that it was using initially in masses of the breast and all the things. So when we see the difference, this is not a hard tissue. So that's why. Second, I used shear wave technology, that is this one. So it means it works very similar to FibroScan. So it sends a wave, and the wave receive it, and then the software make the calculation and give you a kilopascal. So you just push a button, as this one, you see, 1 second, and that's all. So it's a lot of information that we are having from these technologies. And now that I have a clear correlation between the clinical aspect of the patient, the lesion that she have, and now that I have this, so I have to take a biopsy, and I believe I will propose in the future for this patient. Normally, you can follow up, right? But in this case, I have symptoms, probably a radiofrequency will be a nice option for her. So let me take a biopsy now. I am using this is Nightingale. 19. I will use a Nightingale FMB menos aspiración.
Hey, Carlos, can you just talk to us about the choice of the needle in lesions like these, 19 versus 22 versus 25?
Yes, that is a very good question. So how I use my needles, to be honest, one, if it's a small lesion and I have to pass the main pancreatic duct, I will use a 25 gauge needle because the risk of pancreatitis is less because of the size, and you can have very good results. So my second option is 22 gauge needle, if I don't have or I don't need a lot of tissue. But in this kind of cases, this is a difficult case for FMB. It's not so easy to have it. So remember that this is a mixed lesion, right? So we need a very good tissue. So that's why I select a 19 gauge needle. And in what cases I don't use 19 gauge needle? In those cases that are hypervascularization because it's a lot of blood coming. That's why. So in those cases, maybe 25, maybe 22. But this is the way that I use it. I don't know how do you use it, but I know in United States you don't like to use too much like the 19 gauge needle because of the risk of complication, but you can see it's really a smooth the lesion. I can feel that it's smooth, and you see there is some kind of bleeding coming. So I just
Carlos,
finished.
Jean, lovely to see you both. Colin here. I just wanted, maybe you could just touch on the number of passes when you're doing your biopsies. I see you only did sort of 2 or 3 passes there. Maybe if you could just let us know what would be your standard when biopsying the pancreas.
Well, that is a other good question. So the studies that has been showing use FMB show it already that these kind of lesions, just with FMB you need 3 paces. Just one single shot and 3 paces, you will have a good result. But here I am not happy. What I have, you see, it's a lot of blood. So this is not a good tissue. So now I need to change, and I will not use aspiration. I will just use the needle directly. Solo voy a usar la aguja.
Carlos, will you use the needle with slow pull or just the needle with nothing?
My friend, I try to use these other techniques, and I never arrive to be so good as people that are doing. I believe it's a good option, yes, for sure. But well, I am becoming older, I believe. I believe it's a good option, yes, but to me, I never make it work. I don't know why.
Well, we've been talking a lot about there's a lot of ways to do different things. After this pass, we're going to switch to a different room and then we'll come back to you, okay?
Okay, thank you.
So now we're going to switch over to Dr. Binmuller's room and see where things stand with his colonoscopy.
Are we live still?
Yeah, that's interesting. Yeah.
Okay.
I think I can't hear blood.
So one of the reasons was that Hannah has a special.
All right, guys.
herb that I
Blake
think
and Heiko will come back to you. We want to see what Dr. Messman and Dr. Bilal are up to. I think they're closing the defect. So we'll go to them. And then after that, we'll see what the Ecuador team is up to. Thank you.
Different approach.
They're coming back to us in a minute here.
Okay.
Helmet, Bilal, we're back in your room. Can you hear us?
Yes, we can hear you. Can you guys hear us?
Sure. Can you provide us an update of how things are going?
Yes. So the lesion is gone, as you can see. Dr. Messman is demonstrating this beautiful technique of clip with a suture closure to approximate.
Close slowly. Don't fire. Just close.
Yes.
Let's check.
So we're doing clips over the suture line to approximate the defect.
Yeah.
We had a couple areas of superficial muscle injury, which is not uncommon when the lesions are so fibrotic.
So you can see here the line. So the first clip was this one. I grasped we made a loop on the distal part of the clip, and then I fixed it on the muscle and the edge of the mucosa, and then we pushed a bit on the string, and then we put another clip.
Are you done with fitting?
We can now continue the clipping.
See it.
Helmet, are you using this kind of suture and clip technique kind of to do almost like a Z closure going from side to side?
Yeah, you can do it also. Now, I mean, I can now use this clip here, open. Yeah. Like
you have the
X-Tech,
focus
no?
on my hands.
You can now use it here. Yeah, grasp some muscle fibers, and then slowly close, slowly. Yeah.
You want me to tighten the clip or?
and then fire. Yeah. And then we go to the other side and we can try, yeah,
Yep.
to push it a
Beautiful.
bit. Yeah, you see? And always try to grasp a bit of the muscle layers, and you can nicely close.
Showing my hands or no, Alex? Oh,
I
yeah.
was surprised that in your country the people stay only one night or as an outpatient. In Europe, they don't stay for weeks, but at least 2 nights. Yeah.
So you can see the
Open.
lesion. We're partially done pinning it. Our fellow Michael
Close.
Joseph is doing a really good job. But you can kind of see the extent of the lesion here. And Dr. Messman's beautifully resected it. And we were just talking about that, you know, this lesion had a tattoo and a clip on the lesion in the rectum, which made it very challenging. So obviously, you know, a teaching point to all the fellows in the room is that, you know, you don't need to tattoo within the lesion ever, but definitely no need to tattoo in the rectum or near the cecum or IC valve. But you know, despite education, still happens sometimes. But Dr. Messman has
Open.
navigated the fibrosis beautifully.
This is a great demonstration. It looks like everything's coming together nicely. We are going to switch over here to Dr.
you.
Binmuller's room.
Thank you. Thank you.
Nice work.
Great job,
Yeah.
guys.
Thank you. Okay. Close. No. Open. Slowly. Bit my muscle. Okay. We lost it, huh? Close.
16.
Wait a second.
So it's pretty dirty on the right side. We've been spending a lot of time just cleaning and with water exchange, but it's looking fairly, at least better now. And it's with gas, of course. I had to put the gas on. Here's the lesion at the hepatic flexure. We did not see a lesion in the cecum. I can go back in there in a moment to show you, but this is multilobulated. It's definitely a 1S, 2A type of lesion. The tricky part is it's right at the hepatic flexure. In fact, it's kind of hard even making that turn into the ascending colon, which is right here. It's all sort of twisted on itself. And I'm sort of torquing. Here we go. Let's see if I can continue.
So Ken, just from what you've seen so far, what do you think your approach to resection is going to be?
Well, I probably will do underwater, I think. There were a few features that concerned me a little bit. It looked like there was some depression there. Let's see. Okay, this I think is tattoo. Give me a moment here just to get this back in view. I'm going to back off a little bit and see. There's tattoo. So I'm assuming that it's upstream from the tattoo. So I'm going back here. And then everything is sort of collapsed here, the lumen. So I'm trying to find my way. Keep falling back.
This raises an important point as it relates to tattooing colonic lesions. Obviously, we talked earlier about not tattooing too close to the lesion, but I also think it's important as best as possible to photo document and in written form document where the tattoo is in relation to the lesion.
Say whether it's upstream or downstream. This is the cecum, you see, and there's a clip here, and there's a tiny little polyp there of no consequence, and then the IC valve you're going to see down at 6 o'clock, and I think it's right here, right here. Would you agree, Heiko? That's the IC valve here.
Yeah, I think that it's right behind it. I think you would have to push a little harder in there, but like there, yeah.
Oh, you think the cecum is through here?
I would think so. I'm not convinced yet that we're in the cecum.
Okay. The problem is that he loops here tremendously. So you're thinking this is still ascending and we're not yet there. So you can see when I push in, I get this paradox, right? Like this. So, See, I get the paradox here. And I'm trying to see. if I can
Ken, as
get
you're trying
to.
to figure this out, Doug, I'd love to pick your brains on this. What's your strategy? When do you use underwater EMR versus the traditional resection technique,
Yeah, I
injection
just
with
need
hot
another
snare?
set of hands would be great because I
What's your
think
algorithm?
sometimes what
Well,
you have to do
I would
is
use underwater myself. I think it's great. As I said, it's this morning. Its greatest benefits are when you've got something that's kind of in the 20 to 30 or 35 millimeter size range, and you really think that you should remove it on block. You'll have a better shot
the response
underwater.
comes in, right?
And then, so that's number one. As I mentioned, non-granular flat elevated lesions, I'm not sure that we've seen one today, but if they're very thin, and when you inject them, they get even thinner.
There's the
Sometimes
lesion.
they're just harder
Resect here.
to resect. So I think those are the big things. And then there's a lot of advantage to floating things.
Yeah.
Sometimes in the left colon, a sigmoid pedunculated polyp with a lot of bulk, you get
Hoping I
get
can stay
proximal to
stable
it,
in this
open the
area.
snare really big, pull back, and you just can't get underneath the polyp. You keep catching the snare on the head of the polyp. Whereas if you fill it with water, it'll float up a bit off the wall. And there can be other situations in the right colon, especially around the valve, where underwater will make things really, something that's quite difficult in gas will become
Yeah.
really, really simple underwater.
Interesting. Another
Heiko finally started pushing, I think.
Yeah. Ken, while you get in position, we're going to move over to room 14 where Dr. Shah is. Raj, sorry, we didn't give you too much of a heads up, but are you in a position to talk to us?
Always in a position to talk to you.
Fantastic. Before you say anything, we just wanted to review the case first, and then we'd love to see what you're looking at.
Okay, thank you. Calc right here, body calc.
So case 10, it's a 75-year-old male, history of chronic pancreatitis complicated by exocrine pancreatic insufficiency, remote history of testicular and prostate cancer, undergoing evaluation for pancreatic duct dilation. Recent MRCP shows pancreatic atrophy with severe dilation of the main pancreatic duct in the body and tail of the pancreas with an abrupt caliber change at the neck. No obvious obstructive lesions were seen. EUS performed thereafter showed sonographic findings suggestive of chronic pancreatitis, pancreatic duct dilation up to 13 millimeters in the body and tail of the pancreas without a clear obstructing lesion. Common bile duct at that time appeared non-dilated. Here's a picture of the MR. Looks like a coronal image demonstrating the severity of the pancreatic duct dilation. Plan for today is EUS and ERCP with pancreatoscopy to evaluate for an etiology of pancreatic duct dilation. All right, Raj, back to you.
Thank you, Ryan. You did a really nice job with the presentation, not having seen the slides before. This is very good, very nice. Thank you. You know, I decided to repeat the
I've done it
endos-
before.
I figured as much, but we appreciate you doing that. You know, I decided to repeat the EUS primarily to look for any lesion that may have been subtle, perhaps not seen. Can you turn the gain up one more? And so I'm just at the tail of the pancreas now. I had already looked at the mediastinum, celiac axis, and the liver off camera. And I'm just starting the pancreas exam here. And you can see some parenchymal atrophy. There's a calcification right here, which we've already measured, right at the 5 o'clock position with some acoustical shadowing. This is the duct. It's got a little bit of thickness in the pancreatic duct. One of the reasons I set them up for potential ERCP with pancreatoscopy was the degree of pancreatic ductal dilatation, which was about 4 times what we would expect. Body of pancreas here and measure. And so this appears to be a pretty, can you hear me okay?
We can hear you great.
Okay, from here to there. Um, this appears to be pretty dilated. You know, normal is up to 2. It's about 3, 4 times normal, and another stone here actually. Interesting. Now, this patient has no risk factors other than a 50-pack year history of smoking for chronic pancreatitis, and they also have a the other no family history of pancreatic cancer either. Calcification there. That's fine. You don't have to measure that. And then we're just passing down toward this. You can see the splenoportal confluence. If maybe you could show it with the laser pointer, unless you don't agree that that's what that is. But this is the neck of the pancreas here. That's the vessels here. Yeah, these are the. Oh wow, wait a minute. No, that's the duct here. Okay, so that's a markedly dilated duct right in the neck. I'm gonna let's measure the neck, pancreatic duct in the neck. So I would expect he's not symptomatic with respect to pain. Only smoking history as, go ahead a little bit more up.
Hey,
As
Raj.
a risk factor for chronic pain. Yes.
So sorry to interrupt you. Ken is actually ready to perform resection using the underwater technique. Can we please come back to you in a few seconds?
Yeah, sure thing.
Thanks so much. All right, let's go to Dr. Ben Moeller in room 16. Thank you.
All right, this is really tricky because this is right behind the IC valve, and I have a very unstable position, and it's also kind of dirty in here, right? So I'm constantly having to clear my view. But what I'm trying to do is allow this to float up as much as possible. This is right behind the IC valve, and I'm going to use the snare now to help shift this away so that I can scoop it underneath. So I'm using the snare and just pushing this away, waiting until I can maybe find a plane to scoop the snare underneath, right? You see how I'm pushing this away? And I'll keep doing that, but there's a part on the right side that I don't think I have in the snare. So this may not be on block in the end, although I really would like it to be. I'm going to try to maneuver this just a little bit more to see what I can do. Kind of pull back. With the water, I can distend a little bit more and see how it is. I'm trying to scoop this. It's a little bit of an umbrella type polyp, right? So it kind of overhangs. So I have a chance. And I'm going to ask Heiko to hold the scope because it's such a unstable. See how it kind of just floats like this, but I'm losing my position again. But it's okay. I'm going to let everything just sort of float and just wait. You have to have a lot of patience with this when you have poor control of your scope. And right now, it's sort of like I feel like I'm in outer space, right? And it just sort of floats away from me.
It looks like you're getting there, Ken. What size and type of snare are you using?
It's a 33, and I intentionally chose a big one because this is a big lesion, and I would like to get it out on block if possible. But let me just I'm just trying to get this to swivel over this way, turning like this, slowly. So it just demonstrates how much patience you have to have when doing this. And then I have the assistant. So it looks like on the left side, that snare is not quite getting the left side. So I'm just sort of moving.
And it looks like you're pumping water continuously. Do you ever let your foot up off the pedal?
I'm putting a lot because I need that distension to see. And I'm just trying to see what I can do to turn this so that I can get that left edge of the snare underneath this, right? Now it's looking better. Now I'm going to do that jiggle that I talked to you about like this, right? And then you just start to close the snare, and I want to just sort of see while I'm torquing and crimping and then when it's, just hold it there because I want to see how it changes color and want to get a sense of how much I actually captured. So I don't want to cut through anything. I'm looking at the color change. All right.
What do you do to make sure that you don't have anything on the backside?
All right, I'm doing the rotisserie, the French rotisserie here. All right, so I'm torquing like this. À la foncée, oui?
Très bien. This looks good.
Vous voulez votre poulet bien cuit? Okay, so now I think this looks pretty good. I'm just doing the rotisserie like this. It looks like the whole thing is nicely violaceous. And I may have to trim this a little bit more. Maybe I didn't get the bottom part. I'm looking at the far left. But that looks like normal mucosa to the far left. So I'm pretty happy. This is really a tough spot, right? Because it's right behind the IC valve. Now, it's called the two B's, all right? Bubbles and blanching. So you're just going to hold it like this till you see some bubbles appear and you see some blanching. I'm on auto cut 1.6, so this translates with the old vial 300. It was 5 effect and 80 watts. That's what I used to use, auto cut. No, we don't have those settings anymore. So it's 1.6, and then I have force coag 6 if I need some coagulation. For these really villous lesions, I will use some coag, force coag. But I would tell you down in the cecum, you got to be very careful. So the idea with using autocut here is to wait. So this is different from Doug's technique, where he cuts through pretty quickly. I'm waiting. I'm gonna wait while I'm tapping till I see some bubbles and blanching, and then the nurse is gonna cut through. All right? And then while I'm doing this, I'm gonna take advantage of the heat sink effect, and I'm actually gonna give water while I'm doing this. So I'm ready to step on the yellow pedal. Here we go. Wait, 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 start, cut. There it is. All right, so you saw the bubbles and the blanching. Now we got a little bit, put the snare out just a tad for me, just a little bit, and then recess it. Right away, recess it back to stop, a little bit more recessed. Now I can give some water here, and if it doesn't get too cloudy, see that there, right there? But if I can hold the scope for me, if you're very careful, and just make sure that your snare is inside. Push. No, it's good. It's good. It's good. See, it coagulated. That's all you need. I always keep the snare recessed in when I make my dots, right? See, you can get it nicely there. Good. And that's using auto cut. I can use force coag to get more effect if I want more. Look, see, you get this spark. This is force coag. So now I can get, and you're just hovering above the MP. That's all. And I want to make sure, see, I've got the heat sink effect, which I think is so important. It's preventing the deep thermal injury. Now, the next thing I'm doing is I'm going to scout around the perimeter. I'm interrogating around the perimeter. This is where you, of course, need to have really, good high def. And I'm looking to see if anything looks like there's residual adenoma. See, now is that normal? I think it's normal on the left side. I can trim that here. By the way, what you're looking at, that crisscrossing, that's some mucosa. The muscle is behind there. That's not a perforation. So don't be afraid, that's normal there. That's not a perforation. All right, so now I'm just going here. There's a little vessel. I'll get that little vessel here. You can even push down against it a little bit. It's not a problem. This is not coaptive coagulation. There. So if you did this with a hot biopsy forceps, you'd perforate. But with the snare recess like that, it works for it. Look at this. The margins look, I think, beautiful. All right, now what I do is we get biopsies from the margins, but I love to, I close these always, and I use the DAT clip. So do you have any DAT clips?
I can.
Ken, this was a fantastic demonstration. Doug, do you have a comment before we move to Ecuador?
No, I just think it was.
I'll trim it for you. All right, just for you, Heiko.
I would just want to be on the safe side to get this off, and I probably would use a cold snare for this one.
Cold snare?
Because this is
Just
a
give me a
pretty
'ten.
large snare to engage that again. And
I'm happy to show it to you. I do this underwater too. I'll trim this. I'd love to show you trimming.
here in the middle.
Okay.
You could maybe even use
Okay,
MR and see if we
Ken and Heiko, while you talk about trimming the polyp, we're going to move to Ecuador, but I do see a guest just behind you. All right, I'm sorry about that. We're going to come back to him. Let's go to Ecuador and see what Carlos has to show us. Hey, Carlos, can you hear us?
Yes, perfect. Can you hear me?
Yes, we can.
So I listen to you because always I listen to professionals, right? So I did two things. First, my 19 gauge needle was a not good idea to this lesion, to be honest. Second, I have to change with a 22 gauge needle because I needed core. So you have in your left my FMB without bullet suction, right? That one that you remove a little bit the stylet, and in the right is with the same needle, 22 gauge needle from Microtech, the FMB, but this is with the bullet suction. So you see less blood in the right, more blood in the left, but I have more tissue at least in the left. So this is a result. I will wait for the results and we will see if we will make a radiofrequency for probably for this patient or maybe surgery. I don't know. It will
Yeah,
depend on the patient. Well, yes.
Carlos, this was such a fantastic demonstration, just you using technology to help us predict the histology, guide our sampling technique. What we typically do for folks who attend RMIE, we do send follow-up and let them know how patients have done, what the results are on the histology. So please do share the results with us so that we can
Yes.
let folks
Yes.
know. And I'll just take a second to just thank you and your team for all the amazing cases that you've shown today and your contribution to RMIE. Can't thank you enough, my friend.
Thank you, my friend. See you soon.
Yeah.
Ciao. Ciao to everyone. Enjoy Colorado. Amazing place. Ciao. See you soon.
Ciao.
Bye.
All right, let's go to room 14 with Dr. Shah, please. Hey, Raj. Yes, we can hear you.
Off camera, we identified a suspicious lesion, which I've started sampling using a 22 gauge FNB clear core needle. That's by Cook. There are other FNB needles available as well, including Shark Core by Medtronic and Acquire by Boston Scientific, at least here in the US. And then the Easy Shot 3 Plus, I guess, is more FNA, but we kind of use it as a FMB type needle as well. That's by Olympus. So we're just starting to sample this, and what I'll do, and Lindsay is just doing a slow pull technique for sampling. We weren't expecting a mass, but I'll show you. I don't know if you can appreciate this this lesion that Hiro. By the way, I have Lindsay assisting me here to my right. Hiro Isayama is behind me, is providing expert guidance for me. Thank you so much for being here, Hiro.
Okay.
And
Thank
then
you.
I also have Summer and then Tom, our advanced endoscopy fellow, stellar advanced endoscopy fellow. I'd like to say he's looking for a job in Chicago, but I'm not going to say that because we want him to be in Colorado. But anyway, okay, so here we go.
Hey, Raj, can you talk a little bit about the relationship from this, it looks like about a 15 millimeter mass lesion, the relationship to the area of stricture in the pancreatic duct or caliber change in the pancreatic duct?
Yeah, I'm so glad. It's so nice to feel validated that you see this lesion too, because we were kind of going back and forth. Okay, stop there.
At this point, I
And
guess it could just be blood collecting, but I believe you, it is a mass.
but I'm using such a slick needle, it can't be blood. Okay. So let me show you this. I'm going to unlock my dials here. This was short position, short axis EUS position using the linear array echo endoscope. And so I'm going to pull back here and you can see this lesion, splenoportal confluence there, SMA running below, and the pancreatic duct. Let me pause that. You can see the pancreatic duct that is quite dilated, and we believe, and we looked at the papilla too,
Mm.
Well, it says 6.3. It was more than that
Yes.
higher up, right? Okay.
Yes. And this the pancreatic duct many pancreatic stone presence. So then firstly we
Turn
think
the
this
volume
is a
down. Have it turn the
simple
volume down.
chronic pancreatitis. But
Turn my
carefully
volume down
check
as
the
well.
head area and carefully check the caliber change area. So then SHA detected a small pancreatic mass. So then we decided to tissue acquisition rather than ERCP pancreatoscopy examination. So then we perform the FNB now. It's okay?
So yeah, I think, thank you. I can't really say much more than that. He
Mm,
summarized it really
yeah.
well.
Mm,
Because I think this is the area where there's normal,
mm.
when I say normal, the caliber of the duct, and then it transitions to quite
Here,
dilated here,
here.
right?
Yes.
Yeah. Yeah, I
Mm,
got Ryan on one side, here on the other. I mean, I can't go wrong here.
mm,
And then you see the duct quite dilated,
mm,
and then you kind of lose the lesion a little bit.
mm.
Do you guys agree that this is a reasonable concern?
Yeah, Raj, I think it's important for the audience for you to, you and Hiro to discuss briefly when you see this, but maybe don't see, when you see an abrupt caliber change, but don't necessarily or can't convince yourself there's a mass lesion there, how you approach that in terms of biopsy or pancreatoscopy. Can you talk about that a little bit?
From a standpoint of lesion identification, if it appears to be extra outside of the duct,
Mm.
then I think FNA, FNB seems more
Yes.
appropriate for solid mass FNB. And if we were initially, to be honest, looking at it, thinking, oh, this could be a villus lesion within the duct, as you would see, say, a Hera classification 5 vegetative mass that you would see with pancreatoscopy.
Mm.
And I don't know if that answers your question, but
So before the FNB, we already checked the papillary status. The other candidate is IPMN MPD type. So, but both minor and major papilla are opened. So then I back to the head area. So observation carefully.
Yeah, I think in some of these situations, this is a little bit tricky in the sense that the patient has chronic pancreatitis.
Yes.
But when we see these abrupt caliber changes, oftentimes, we're not convincing ourselves we're seeing a lesion, and it's well within reason to biopsy the area of the abrupt caliber change. Oftentimes, we will get a diagnosis of either high grade dysplasia or malignancy, even when you don't see an obvious mass at that transition point.
I'm trying to avoid hitting the pancreatic duct and that vessel too, but I think I'm in there. Yeah. Okay, go ahead and clear.
Right at the front.
And
Because
then
we
slow
see
pull.
the room as being.
Lindsay tells me there wasn't much, and no core sample, or it was liquid. Okay, so that pretty much means we're not going to see much. Let's see.
Mm.
We're going to try another pass here. These rapid kind of to and fro's. I think when
No,
you're
it's not.
starting out with EUS, you could always lock your dials a bit. Not the dials, the delivery thing, the handle. And then that can allow you to punch it a little bit without going into a duct or vessel. But I think this is the best way to try to shear the tissue.
Raj, how many passes have you done so far?
This is just my second.
Got it. Oh, looks like they may be ready to show us what the on-site cytopathologist is seeing.
No.
Yeah, we should probably give them a heads up if they're gonna. Oh, it's on? Oh, okay.
Mm.
Are we capturing cell cytology? So with our Provation capture, which is a nice feature here, we can capture the cytology onto the Provation report. a very nice feature that we can do with Provation. Clear here, or stop here, I mean. But I don't know if there was much there.
So
I don't think we're quite ready to look at the slides as yet. We can keep the screen on Dr. Shah and the EUS image.
So I think that I did see calcifications in the pancreatic duct as well as in the parenchyma. And we did identify a series of patients between our center and uh, and Baylor or Isaac, Dr. Reitman down in Texas, and of performing pancreatoscopy in patients with unexplained calcific chronic pancreatitis, and identified patients with main duct IPMN as an etiology. That may not quite be the case here, but I think if you do see patients with a markedly dilated pancreatic duct as well and calcifications without obvious risk factors, then considering pancreatoscopy, even asymptomatic, a very reasonable approach. We've published this information, small case series, but to exclude IPMN, of course, it depends that if the patient is under is appropriate surgical candidate. I wouldn't pursue it in a patient who is not an appropriate surgical candidate, but in that setting, it seems reasonable to pursue. I'm just looking at the cytology now. I'm not sure we're seeing much on that first pass, and I'm getting yeah. You keep going, Dr. Shah. I got that from Arixa. That was a nice way of saying you're just seeing contaminant. You know, contaminant is one of those words as an endosonographer that it just I don't know. It makes you second guess kind of why you're here and what you're really accomplishing. Should somebody else be doing this procedure and not me? I'm feeling a little bit of that right now. But in any event,
I know
that's
it's
where
it's
we
one of the
are. So
most
we'll see what the
frustrating
second
things,
pass
right?
shows.
It's one of the most frustrating things that you hear as an endosonographer.
Well, I think as a cytologist, cytotechnician, it's the delivery of the information. You know, the delivery of the
All right, here
information
we
is
go.
we're all excited and it's something, and they walk in the room and you got nothing, and you're like, oh, you know, it's like a dagger. And then if you get your heart rate monitor on, it's probably going up a little bit, and you're frustrated. You're blaming everybody except yourself, and
I know,
that's the thing.
and
Everyone's laughing, yeah.
you try and make yourself feel better. Look where my
Now
needle
that
is.
looks
It's right in
worrisome.
the center of the mass. How can this not be positive?
Yes, thank you. Oh, okay, so it's not just me. Once again, thank you for validating my lack of proficiency. Okay, here we go. What'd you think, Hiro? So Hiro is a gastroenterologist, but he also is an interventional radiologist and an oncologist. So we got the true expert here. And what do you think about that cytology? But please don't use the word contaminant.
Yeah, sorry, I don't know about the pathology.
Okay,
Yes,
okay.
that's
Sorry,
actually
okay.
actually just we don't have yeah performed on-site
Right.
pathology. So the passing using the FMV needle pass 3 or 4 times maybe enough. So recently the our
Shark attack.
pathologist they cannot come
Zoom in
to
on.
our room. So and I want to ask to Raju. So the recently we
Clear?
check the
So
comprehensive
far.
the genomic examination abnormality checking. So do you perform the genomic change testing? Do you perform genomic genomic examination?
We sometimes are asked based on clinical trial
Mm,
eligibility
yeah.
for sequencing.
Yeah, but at that
And
time we use 19 gauge needle. Switch to the 19 gauge. So because 22, it
Right
is a
now,
too
yeah, we can
small
really
for the
yeah.
foundation one. So then recently we check switch to the 19 gauge needle FMBA. Mm.
Yeah, this.
I think even in this small of a lesion, you'll consider 19?
Mm. Yeah.
Yeah, really? Oh
So
boy.
try.
Let's just do quick suction on
Yes.
and off because it's a
Yes.
little bloody
Yes,
on and off.
and we should check the Mohs technique
to get a white core, and to get this one to the pathological area, and then comprehensive genomic anomaly checking.
I see.
Okay.
And that helps to tailor the treatment? That helps
Oh yes, yeah. But very few. So the match the drug. So druggable mutation is a very few. But I experienced two cases of the matched therapy. These cases, 2 year continuous complete resolution. So then very few, but we should try. Okay, how about the result?
Well, I
Colin
heard
and
not much from
Mohammed, can
Kusuma.
you guys
Thank you,
talk? And
Kusuma.
Alan, too, like at your centers, what's your
We've got a friend
algorithm
here.
for these lesions? How many passes would you do? Do you have on-site cytopathology evaluation? Do you go by modes,
Change the
by
technique.
rows? What do you
Did you
guys
get
do?
much tissue on the last one?
Yeah, we were just discussing it now. I think.
Oh, sorry, just one second.
Yeah, we can hear you.
Yeah, cool. So Dr. Smith here, and I was just taking a look at this second pass, and we do have quite a few benign ductal groups. And then there are a few groups that are slightly under a little bit of.
Sorry, we can't hear her.
Yeah, we can't hear.
Can you let the cytologist know we can't hear? Can we do the wet suction? Do that heparin's flush and... What do you guys think? What should I do? Should I switch to a 25, easy shot 3? I don't think I'm going to do a 19 gauge. Or try a wet suction technique, or
Yeah,
abandon this.
Raj, we're going to pull our panelists to comment on this. So give us a second.
Okay.
Raj, Colin, yeah. Yeah, fantastic. I mean, this is a fantastic case and often
Well,
the
you're
clinical
being
situation.
kind, but-
No, honestly. And the question as to whether or not we've got on-site cytology, we do, but we don't use it much, largely because of exactly this situation that we're in. That you don't really get that feedback from it. So we wouldn't use a 19 gauge here. We were chatting about it earlier. I think 19 gauge, there's data for it being beneficial in the liver. But the problem here is that you just increase your disruption of it. And for the pathologist, I don't know, for example, that desmoplastic stroma and that architecture is really important for them to call adeno. And you disrupt that with a 19 compared to a 22. So we wouldn't do a 19 here. We would do a 22. You could potentially do a 25, but a 22 would be.
How many passes?
Again, that's what we were touching on a little bit earlier. I think we don't do it under any type of suction. We would do slow pull technique. The number of passes, the data for 3 passes or actual 3 stabs at it comes from lymph node biopsies.
Sure.
In the pancreas, still it's 8 to 10 for each one. And going up to 3 passes, one doesn't have to do that. But there seems to be a plateau. So doing more doesn't seem to benefit to it. One point I would like to make is that, what we would do here is you've got a CT scan, less or 1 to 2% isodense lesions would be adeno. The rest are generally hyperdense. You don't have that here. You've got there is a lesion here, but if you didn't have this lesion, and even in the setting of this lesion, unless you've got abrupt color change with hypoechoic walls and thickened main pancreatic duct, we would potentially biopsy that. But we would be concerned for IPMN here. So what we would do is puncture the main pancreatic duct, we'd do cyst fluid analysis, and we would use a combination of that. And if you have, the 3 out of 4 feedback from this cyst fluid analysis, you've got a 92% sensitivity for IPMN. And with that size main pancreatic duct, you fall into the surgical group. So that's how we would manage this.
Hey, Summer.
I guess the biggest concern, just before everyone else comments, sticking a needle into the main pancreatic duct, Colin, is risky business. Risk for PD leak, risk for pancreatitis. So I would be worried about that.
Yeah, completely agree. And especially in the setting of an atrophic pancreatic parenchyma. If you don't have an atrophic pancreatic parenchyma, you've got an interface that will naturally again close and you won't generally see a leak. Theoretically, that is the concern. We just don't see it, and we do a lot of main pancreatic duct puncturing. Yeah, with the 22, we wouldn't puncture it with the 19. And one of the downsides to it is the sort of the mucus nature of it. So you just have to be a little bit patient. But we wouldn't puncture with the 19 for sure.
You got it? The heparin, you did it? Oh. Oh, they are.
Raj,
Well,
my
what was
my
the, I
typical
missed the
practice.
panel.
No, my typical practice in this situation was we start with 4 passes, slow pull, see what we have on cytology in the room after 4 passes, and then go from there. Make sure we have a rinse bottle for cell block, and then if we have a diagnosis, great. We maybe take another pass straight into cell block, or if we're getting there but not quite there, we'll do some more passes for slides.
Did we not have it? Yeah, no, that makes complete sense. I was wondering about changing needles, or you wouldn't change needles then. I'm worried about this lesion. He has episodic pain once a week. That's short-lived in the right upper quadrant, but
I generally stay with a
not enough to
22.
consider
I stay pretty
pancreatic
close with a
stenting.
22 for everything nearly all the time.
Yeah.
I would not change my needle either, Raj.
Okay.
And
Different
you've got how many
technique.
passes, and what was the final
3. They
feedback?
read it as atypical, but not enough. Just a couple of groups they thought were atypical. I
And
think
how
this is
many
the third
passes?
pass.
How many passes have you done
3
so far?
passes. All right, just do this. 3.
Okay. I think, Raj, we've got data from randomized control trials demonstrating this plateau effect. Beyond 4 to 5 passes, you're not going to increase your yield. What do the others think on the table?
Hi, Raj. This is Momin here. Again, a nice case, and we're all interested in finding out what this turns out to be. But our practice, we have rose cytology at our practice, but I do not use it because we have now needles that acquires really big chunks of tissue. So our biopsies are like similar to how we do biopsies with like a biopsy forceps. You get good chunks of tissue. And there was a study recently, I think GIE, that compared both and found that there was no difference in the yield for solid pancreatic lesions, but the time difference in the procedure was significantly different when you use ROSE. It's much longer procedure. And sometimes also with our pathologist, and I get their point, they always want more tissue. So we would be at like the 5th or the 6th pass, and we have some suspicious, but they still need more. And at some point you have to stop too. I mean, their best interest is to get as much tissue as possible, but we as the operators too, you keep in your mind also the risk of doing more and more passes. You're causing tissue edema, you can cause hematomas, other complications. So it's always kind of a balance between this and that. So our practice in general, use an FMB needle. 22 is like the workhorse for solid lesions. And we do 3 passes. And if you see enough chunks of tissue in there with not much blood, typically that's it. And we send it to pathology. I want to also get the panel's opinion. Which types of 22 FMB needles are you guys using too? Like the one we typically use is the Acquire. But I don't know which types are you guys, and if you feel there are differences. We know there are differences in the tip design, but do you think there are differences also in the amount of tissue acquired based on the tip design?
Maybe, right?
We typically use shark core, 22 shark core for a biopsy, and then for FNA, we're using 22 slimline from Boston
Put it in
Scientific.
cell block, you think?
Yeah,
do
we're
one
pretty
more
much
pass
using the
with cell
same
block,
Acquire,
and then we're gonna
and
go to
then we have the Trident needle from Microtech, which is similar, and we do that. We don't use FNA needles; it's FNB. Yeah.
Even for
You would
floats?
use the heparin?
Even for float, like you use
yeah, we
FMB needle?
we wouldn't change it. Yeah.
And I think on-site cytology, I think societal recommendations say when using FNB, you do not need on-site cytologists anymore.
The one thing to be kept in mind about doing just straight cores is, and when we see patients who've already had a core biopsy or prior FNA and come back, I think in that situation, I feel really obligated to do FNA on that second time because I don't want to be the second person who didn't get a diagnosis in a patient who likely has cancer. So I do think there is, based on unit dynamics and hospital dynamics, a role for just doing core biopsies and then going to ERCP, for example, for a pancreatic head mass. But my general practice is for anybody who's coming back with prior non-diagnostic EUS, I always do FNA just for fear that we're going to have another non-diagnostic, which is just not great for patient care.
And I agree with that. That's an exception for the rule not to use Rose cytology. If they're coming back, or if it's mine and it was not diagnostic, I would use Rose cytology when they come back. But if it's just upfront, and we rarely really need to do that.
So I think we're going to do one more pass. Well, I appreciate everybody's commentary.
Copy.
I'm going to do a fifth pass for cell block. They say the cell block is robust, but
Hey, Raj,
depends what you
I
put in
have a
it.
question for you. Are you worried about pancreatitis? Are you doing anything to reduce the risk of pancreatitis at this point?
We had given endomethacin because I was anticipating ERCP, but I don't typically do that with EUS. Sharpen here. So yeah, I did. Okay, but I'm thinking that I might want to do a quick ERCP here because this duct is really quite dilated. The lesion is soft, slope hole and clear, or clear slope hole. The lesion is soft, and also that Hero had pointed out, it is quite soft. And also, just the degree of ductal dilatation really bothers me. And if there is a lesion, it's going to be right in the head. So if we can get in there pretty simply, we may do pancreatoscopy to take a look. And so that's what I'm thinking after this pass for cell block, unless others have, or I'd be certainly interested in other, unless, what's that?
Raj, sorry to interrupt, but I have a quick question here. What's the location of this lesion?
It's in kind of the head. It's in the head. Would you say head? Here?
Yeah, so just tail side of the papilla. Very
So this
close
is
to
like
the papilla region, yes.
So this is like ampullary area. Are you like in D2?
Yeah.
From D2, we are performing the
So here, let me
FNA,
show you the
yes.
rest of the PD here.
Yeah, it can be. But it looks dark.
Raj, so it sounds like you will be doing an ERCP next, correct?
Yeah, you see that stone there? I think we should.
I agree with you. All right, Raj, we will take a 15-minute break, and then we'll come back to watch you do the ERCP.
Last question.
Yes, of course.
Yeah. So I just want to get like yours all practice when it comes to doing a combined EUS ERCP. Do you typically want to start with the EUS or start with the ERCP, and what's the pros and cons for each approach? I personally, initially, I used to start with EUS first and then switch to ERCP. My thought was I would take a look at the anatomy and it helps me get a sense, like do my own imaging. But I notice when I do FMBs, especially if it's like a head lesion, my cannulation rate like becomes like falls down. It becomes harder to cannulate. I think it creates a lot of edema in the area of the papilla from the passing of the FMB needle. And then I realized that when I do the upfront ERCP, the ERCP is much faster. And then I do the FMB at the end. Some would have the concern that if you put a stent in there, it's going to be in your way, but I never really felt whether a plastic or a metal stent would be in my way. I would biopsy at the end of the stent because that's where the stricture is. But I would like to hear from you guys, how do you handle those when you have a combo EOS and ERCP for a mass?
Yeah, I'll just give you my quick response. I'm still sticking to EUS plus followed by ERCP because I think it makes a difference what the indication is, right? For this patient, if you found a hypoechoic lesion in the head, you do FNA or FNB, you've made the diagnosis. This patient does not need an ERCP because the LFTs are stone cold normal. On the other hand, having that diagnosis, we do have on-site cytopathology, by the way. So having that diagnosis available to us does guide our decision decision or gives us the option of putting in an uncovered metallic stent if that's what you're going to do for biliary obstruction. So I still, your point is very well taken. Yes, edema, bleeding can be a nuisance when you are cannulating. What do you guys do?
I do EUS first. I do think, obviously the issue about the stent getting in your way on EUS comes down to the size of the lesion and location of it. If it's a 8 centimeter lesion that goes from the ampulla to the mid body, it's not going to matter. But if it's something a bit more subtle, then putting in particularly a metal stent may make things a little more challenging. So I agree. I stick to EUS first, and then go to ERCP.
Yeah,
Colin
not
Allen?
add much. US first, yeah.
We do US first as well.
Okay, but I think this is an intriguing concept, obviously. All right, we're going to take a 15-minute break, and we'll be back at 3:25. Thank you so much.
Yeah.
Nice case.
Obviously, all morphology is but you think they're doing standard CO2 resection now? Did anyone a cup of coffee? Yeah, that's right. I'm good.
I'm going to go with you.
There are times when I just feel like I see better because it's a very large piecemeal section, and if I'm underwater across the whole thing and there's loose pieces of tissue floating and stuff, and it's just kind of like I get tired of it, trying to get them out of the way. You're blowing water.
Yeah,
and
yeah,
there's
it's like
pieces of loose tissue
spinning around in front of you.
Yeah. But, I mean, there's the argument. Really. Plenty of people are just made a conversion.
Yeah.
Michael Burke not doing one of them.
Yeah.
The water pushing your garden was a thing. Push the leaves in the house.
I was so wrong. I felt that was good.
Yeah, it's fine. Yeah, I mean, I feel like it's like a smaller. Yeah, I mean, it's like a polished feel. It doesn't. I mean, it doesn't have like the same. Yeah, it's just not that. Yeah, there's better quality. That's not the main thing. Yeah, I mean, I think actually like if you're like I did for years, it's like we just like because you're going which yeah, yeah. Yeah, I know. Yeah. It kind of. Pushing out my palate. Yeah. Yeah. I did the highest PPR. Trust anybody else? So, yeah. They won't let me do it. Yeah. So he's like very funny. Right. I didn't know. There's a report of. Just say I said right. Right. And I have seen yeah. I mean, guys, it's good to say, yeah. I think I'm talking. There are now. But it's 8 years. You know, when I started, I didn't the first one. Yeah. I was gonna say, that's not okay. I do it. No, well done, Chris. Yeah.
Hey, Sean, I'm on.
With the second house. And we still do it. I'm checking the word.
Okay, I see Raj cannulating. Tell me again which room will we go to after that?
Gotta reach around. Yeah, good hope like this. Yeah. Okay, one second, I do it.
Copy that. Thanks.
Yeah.
Unfortunately, we still have 10 minutes left for our break.
No, I didn't know.
That sounds good. All that blood probably from the sampling.
I just want to say, my institutional.
Hey, man.
I didn't catch you on the way in. I just wanted to say.
How are you?
That's all I wanted to say.
Thanks.
It's always-
for everything.
It's always a pleasure.
Likewise, likewise.
My partner. I think that's the reason why the set of stars. Sure. It's custom. It's custom. Yes. 4 or 5. I haven't counted those. Yeah. That's no good. That's like H-grade. I don't know what it costs. Hey, the next week. We are somebody or the RMIE smart. Sometimes. Oh, yeah, a little Jim, I'm sure. But I can actually. You go to the right hand, you can see. That's a split that. That's check out. And I would say, top. Oh, wow. Yes. Close enough to the grader.
But I think like the issue was that there was not like
Yeah, it's, you know, hard to make it work. So it's eating. Yeah. So are you saying patients? Bill, he's still. So it shows that I still don't. I should have been off this one. But how are you? Yeah, that's where the, yeah. No, I totally said it was okay to push it out, but. Yeah, those are, you'll be able to, it'll still be there. Set on the draft, I understand. You know, everyone's there. Yeah, it was like, yeah. Well, how's that go? East, yeah, it's okay. Yeah, yeah, which is nice. Sports services is in efficient. Was sorry, they feel because they leave it. They worse are still sellers. She's something less of it. I'll make up by it and it's those stuff. And that's another place. There is I tell her that every day, so yeah, but. Yeah. You always tell you never.
The Fuji cap?
The Fuji cap, yeah, or the
She's not there.
This is Steris one, yeah.
Yeah, this is the Steris one we're using, right?
Which one? What she's done with the women's endoscopy is quite impressive.
Sure.
Really,
With the. So I come from a very chauvinistic discipline. And
Yes,
just I love this.
yeah. Yeah. I agree. It's well intentioned, it's well run, it's, I think it serves a purpose. Yeah. Well, we're not a typical surgeon. I mean, of the older generations, many sadly were like that. I think it's changed a little bit, but it's still more than non-surgical.
Oh, I mean, 100%. I mean, there is very little personality, enjoyment from surgeons. I mean, they are.
Oh, really?
Even the
It just changed altogether. No?
It's better. It's better, but it wears off. They 10 years, 15 years into the. I mean, I'm not joking, but things that you take, and I've heard things like, Mile Wardrons, they would say.
Oh, I just want to know what Raj is thinking. How much longer is he going to?
Oh, are you serious? I mean, it's so when I was at the university as a fellow at Sabiston, invited.
Okay, sounds good. So after the GPOM, we're going to go to 16, right?
Well, called me up, his office called me up and said, you speak French? Because I said, would you like to sit at the table with us? And so I showed up at this place. It was Sabiston, the number 2 surgeon, number 3 surgeon, 10 surgeon, all in a row.
Got it. Okay.
Business was
We'll probably go to Raj after we spend some. So
I love this program because
I'm getting started here, guys. Ryan up here and he's going to start.
Yeah.
You have this.
Yeah. And it wasn't important.
So welcome back from the break, everyone. We're going to introduce case 11. It's a 57-year-old male with a history of interstitial lung disease, chronic thromboembolic pulmonary hypertension related to Sjogren's syndrome, who underwent bilateral lung transplant with a recent course complicated by reflux symptoms believed to be secondary to gastroparesis, who was referred from the lung transplant team for gastric peroral endoscopic myotomy. A Bravo pH study showed borderline pathologic esophageal acid exposure with an exposure time of 5.9% and a Demeester score of 17. High resolution esophageal manometry demonstrated ineffective esophageal motility. Gastric emptying study showed 18% retention at 4 hours. Gastroparesis cardinal symptom index was 2.1. You see the subscales noted there. EGD recently demonstrated a moderate amount of food within the stomach. Patient has had pyloric Botox injections with no sustained symptomatic improvement. Plan for today is gastric poem to minimize the risk of aspiration in the setting of bilateral lung transplant.
It's fun to be here, man. It's fun to be here.
Hi, Dr. Messman. This is Ryan, Dr. Thacker as well. How are you guys?
Hey guys, how are you?
Hi, thanks. Well, yeah, we have already started. Initially, I couldn't pass pylorus, and I didn't try to pass it. So for a G-form, I think the tunnel must not be very long, so I usually use 2 to 3 centimeters, which should be enough. And then the submucosal entrance was very quick possible. So we are now here in the submucosal space. I use a triangle knife with jet function, and yeah, I try now to approach.
And are you? And he's just using a spray coag setting, is that right, or a precise coag?
Sorry?
Are you using spray coag setting or?
Yeah, spray.
Spray. Yeah. It looks precise. Yeah, might be a precise set, but different ways you can apply the coag in these tunneling type procedures. I know you saw one earlier today with Dr. Bilal doing the esophageal poem, and so here he's just going to inject to expand this tunnel a little bit. I'm curious with the panel. We were just talking before, but I think when it comes to GPOM, you've got to carefully select your patient as to those that would best respond. Someone with idiopathic gastroparesis or diabetic gastroparesis. Curious with the panel's experience, what do you guys, how do you guys kind of select your patients as well?
Yeah, I think that's a critical piece. This is a completely kind of different animal than esophageal poem in both technical ways and also just the patient population ways. So oftentimes patients with gastroparesis have maybe some other things going on with some functional symptoms that overlay the true gastroparesis symptoms. So it is critical to make sure you're picking appropriate patients who we truly believe meet diagnosis for gastroparesis, of also who have demonstrated, tests to suggest that yes, it's gastroparesis, and the functional symptoms have kind of been sorted out. In addition, patients really should be tried on kind of more standard therapy prior to going down this road. That's a more typical pathway, I would say.
Yeah. No, really good point about trying.
Hi, Sham. This is Momin here. So our protocol is basically to exclude any reversible risk factors. So basically for diabetics, you want to make sure that their A1C is controlled. And then we typically have them try medical therapy first, if they can be candidates, if they can tolerate it. We know with Reglan, there are possible neurological side effects. And it has a lot of also interactions, especially with some like psych medications and stuff like that. So we try to control any risk factors. We review their medications as well, if there's anything that would reduce, like delay gastric emptying. And what we started to do actually for about a year now is that we do endoflip for the pylorus before doing GPOMs and make sure that the distensibility is low. The cutoff for the pylorus is different from the one for the LAS. So LAS is 2. For the pylorus, there was no like clear consensus, but 9 is a reasonable cutoff. So we want to make sure that their DI is below 9. If it's not below 9, we typically do not perform GPOM on them, because we know even with the gastric emptying study that the contrast is staying in the stomach, but we don't know really for sure why is it staying there. Is it the gastric contractility or it's the pylorus that's hypertonic? So I think the endoflip is a very useful tool. And the other advantage for the EndoFlip now is that, as you said, the response from GPOM is not as robust as EPOMs, for example. So when patients come back with symptoms, we can repeat the EndoFlip, and we have an objective measure to where the distensibility is with the pylorus. And if we see improvement, that at least means our myotomy is well done. And then any repeat intervention at the pylorus is not going to help with that. So that's how our protocol is for now.
Yeah, no, excellent points. Agree with all of that completely. I think EndoFlip can be a great tool for these patients. As you can see here, it looks like we're coming up on the pylorus, and Helmuth is just kind of going to dissect a little bit over that pyloric muscle to give himself some space to perform myotomy as well. As we're talking about this as well, do you all prefer greater curvature approach, lesser curvature approach? Is there any preference from the panel's approach? Obviously, you're seeing Helmut's, approach here.
So my standard approach is about 4 centimeters on the greater curve, proximal to the pylorus. I typically will use a Boston Scientific Pro knife for the bulk of the procedure, but then use an insulated tip knife to cut the pylorus. I get a little bit worried once you get that close to the duodenum to make sure we don't get any inadvertent energy to the duodenal wall. So that's why I like the insulated tip knife in that situation.
Yeah, that's a really important point is using the IT knife to do that pyloric muscle myotomy in order to protect the thin duodenal mucosal side on the other end as well with the knife. So great. So Helmut, what are you thinking so far? How do you feel about this? It's looking pretty good tunneling to me so far.
Yeah, so, oops. I washed myself. No, with a triangle. Yeah, I think we made a nice approach. So in between, you see, I always go back, check my position. We're approaching now here directly the pylorus. I didn't pause it so far, but this nice bulge shows me that we are now close to the pylorus, and I think this must come now, right now. Or do we enter here?
I think one important point for the audience is when doing this procedure, particularly as you approach the pylorus, it becomes incredibly important to stay as close to the muscle as possible. If you start to change your trajectory a bit such that you have submucosa above and below your scope, you can inadvertently start tunneling in the duodenum and things can get a little bit awkward. So by staying really, really close to the muscle, the closer you get to the pylorus, invariably it will be obvious when you run into the pylorus. Sham, we're going to switch rooms briefly and then come back to you guys. This looks excellent.
Yeah. We'll let you know when we're about to start the myotomy.
Sounds good. Raj, can you hear us?
Me okay?
We can hear you now.
Yeah, aging process has made my ears more sensitive. Okay, how about now?
Perfect.
Oh, wonderful. So what happened here is that I'm doing a minor sphincterotomy. I'll explain what we're doing, why we're doing this. We're on 131. 131, going up just a little bit. I went to a little bit of a smaller tome. Oh, you guys didn't see any of the cannulation?
No, you got to catch us up there, my friend.
Okay, so this is the minor papillotomy right here. So I'm going to trace through, okay, relax there. As we're exchanging devices, I'll explain what we've done here. The bleeding is from my EUS sampling that was a bit of a flail, but maybe to Ryan's point and I think Momin's point as well, is that we put a couple passes directly into cell block and see if we do end up getting some answer. But I was worried enough about the lesion that I pursued ERCP. And on the film here, is Tom in there? Can you scroll the images, please? So, oh yeah, this one. Oh no, do the scalp film. Yeah. So you can appreciate some calcifications, which we expected based on the EUS. Next slide.
Raj, give us a second. Can we zoom into the fluoroscopy image just for this part of the discussion, please?
I don't know how to zoom in when.
Well, we're just
Oh,
going to
you mean a
prioritize
spotlight?
that. Yeah.
Spotlight it.
Yeah.
Spotlight it. Okay. We're getting a 6 hurricane. 6 hurricane. So let me know when you have the spotlight.
Yeah, we do. Now we can see
Oh,
the
wonderful.
fluoroscopy images.
Okay, so this wire and the sphincterotoman wire were through the major papilla, and I believe I was hitting a stone. Hero, maybe back me up. We think maybe a stone.
Yes,
I'm
yeah.
putting words in his mouth. Yeah.
Yeah, so and also stricture there.
Maybe stricture.
Yeah. So then we think that this is a sort of benign stricture. Maybe we suggested.
So we couldn't get across it.
Mm.
I don't know if you guys noticed as the hurricane was going across, there was already a little bit of air in it. Lindsay wasn't putting air in it. I know she wouldn't be doing that. But go a little negative pressure though. Okay, there we go. Lindsay's great. I would say, no, you are great. What? That's not sarcasm. That's about sincere as I get. Wait. Oh yeah. So then, thank you, Tom. Tom's redirected me. So we are now, let's just dilate right here. So we tried angled wire, could not get in. To Ryan's point during the cannulation talk, it's not like you just keep switching a bunch of devices. You know, you just see the obstruction. I couldn't get across it. Hero's point, you can go all the way up. Hero's point about stone or stricture, not quite sure. Then I thought, let's go through the minor. So we're through the minor now, and he's got a markedly dilated duct. I think he deserves at least a pancreatic stent, giving his periodic abdominal pain. I don't think there's a waste there. There's some resistance here. Go ahead and go balloon down. Passing the sphincterotome across. So I'm dilating with the 6 millimeter hurricane. Let's go right about here. And then we're going to do, just to try and understand why he has calcific chronic pain and to exclude IPMN. That's sort of why I'm performing pancreatoscopy. We'll go through the minor papilla and then leave a stent in place. And I don't know if any of that sounds interesting, but if it doesn't, you guys can certainly go to another room while we're getting this situated. But you can see a waist in the balloon, the upper third of the pancreatic balloon.
Raj, two
We'll hold
questions
this
for
for
you.
about a minute. Yes.
Are you starting to maybe convince yourself that there isn't any malignancy here, number one? And number two, now that you have access to the main pancreatic duct, either prior to or after pancreatoscopy, are you going to brush the duct, biopsy it, anything like that, or just directed by your pancreatoscopy?
Yes, the latter. Okay, right here.
So Raj, we feel bad that we missed your cannulation through the minor papilla. Anything that you want to share with the trainees? Anything different about minor papilla cannulation versus standard cannulation? Did you give secretin before you cannulated?
Did not do secretin. In fact, I was close to just bailing, to be honest with you. But I would say that, is it up to a minute? We just use a wire-guided cannulation, very tight stricture there. To your point, Ryan, we may biopsy that area because I don't think that's stone. And to address your question, Sachin, it was mostly wire-guided. In fact, the minor papilla, as Glenn Lehman used to say from IU, you don't touch the papilla, the minor papilla, except with a wire. And often that's what I approach as well. Now, sometimes you do have to touch the papilla with the sphincterotome, or I mean with the tome. But in general, I try wire guided, engage it a little bit through the minor, and then you can pass a device through, inject a touch of contrast that distends the duct. Has it been a minute? Distends the duct a little bit and can sometimes facilitate your wire. That's a really tight stricture. That is really worrisome. See that waist? Do you guys appreciate that? Here, let me see.
Yeah, we do.
Are you concerned that you may not get the
Wow.
pancreatoscope through there?
Yeah, but maybe we just get to it
To
and
it,
look
yeah.
at it and maybe biopsy and then get a stent in, maybe 5 French stents, 7 French. So why don't we come down here and then we'll take the pancreatoscope. Is that helpful? But it was very angulated,
We go to 15 after this, Sean?
meaning the duct was tortuous.
Raj,
So we were able to straighten it out a bit. Yeah, go ahead.
I have a
Interrupt me at any time.
couple of questions here for you. So, how do you know that you're not dilating next to a stone? And would there be a concern if you're dilating the duct next to a stone? That's the first question. And then, what's your guide for the size of dilation? You said here you picked a 6 mm hurricane. So, how did you decide on that size of the hurricane versus, for example, like a 4 mm?
I was anticipating pancreatoscopy, so I chose a balloon a little bit higher than what I normally would consider for just placing a stent with the
So,
initial procedure. As far as the size, I felt that the degree of ductal dilatation seemed like, is there a certain lube
so
or
I agree
spray?
with the 6 mm dilation because the 4 mm dilation it's difficult to insert spyglass. So then a 6 mm. So I think the better choice. I think.
Hey, Raj, that was a beautiful demonstration. If it's okay with you, we'd like to go to room 15 to see what
Yeah,
Dr. Massaman
absolutely.
is up to. Thanks, Raj.
Out? Yeah.
Helmet and Sean, we're back with you. Can you hear
Yeah.
us?
Yeah,
Yes,
yeah, yeah.
yes, yes.
Okay. So we were, I was a bit lost in the third space. Sometimes I think it was too deep. So, oops, this is the pylorus. I'm just entering here, and you see here I cut some muscle fibers, and it was too deep. I think the approach must be up here. Yeah, so this is the line where I have to go, and we all agreed that I will continue here.
Yeah,
Yeah.
up and
Out,
up and
out, out, out,
up more. Yeah, up more.
out, out.
Yeah, in this
Yeah, we let you
situation,
go.
sometimes I feel like when I'm tunneling, you're not necessarily tunneling in a straight line, but you're almost just
Yeah, yeah.
climbing that pyloric
It's
ridge.
it's always a sigmoid wind, similar to the achalasia, sigmoid
Yeah.
achalasia.
So
Yeah.
here you can all appreciate the submucosa is up here, is right in front of us now, as compared to how easy you can lose yourself and go down into the muscle there, which can then leave it very challenging. But Helmut did a great job of just recovering that track to bring us back.
A question for the panel as well as the people in the room. This patient got pyloric Botox. Does that bother you in any meaningful way prior to doing a gastric poem?
Uh, it's a good question. There are some studies who show the benefit, but also studies who don't convince that positive response to Botox does not predict the outcome of GPOM. My experience in our unit is if the patient responds to Botox, then in the majority, um, the GPOM works well. Yeah, but he didn't respond, so I would not exclude. I mean, this is meanwhile a safe procedure, so I would really try out. I would really try a GPOM in this situation because if you have no other possibilities with drugs, then the quality of life is really bad and influenced.
And so,
Moment,
just so all of you are aware, we're constantly checking the patient's abdomen, making sure they're not getting any distended, severe pneumoperitoneum, anything like that. The air is, of course, off. We've switched the patient to ultra-low CO2 on the regulator. These are steps that we take immediately when we come into the submucosal tunnel, of course.
So I'll comment back on the Botox question. I think there are two elements to it, prediction of response, and then Ryan maybe also wanted to direct us towards the technicality part, if it makes it harder. I think on the esophageal side, it definitely makes it much harder to do a poem after Botox injection in the LAS, but on the gastric side, we really don't observe that much. I think maybe the nature of the thickness of the submucosal layer in the area different compared to the esophageal submucosa. On the response side, the latest study I read was actually showed no correlation in response, but showed that the group that had Botox, whether they responded or not, had better response to GPOM. They couldn't correlate it to positive or negative response to Botox.
Yeah, I would have to say I'm not a big believer in Botox causing fibrosis. I guess that precludes any of these tunneling procedures. The point I would make, I think that gets back to is making sure that when we're doing intramuscular injection, either the pylorus or the LES, that it's intramuscular. If we're seeing fibrosis from Botox in the submucosal plane, then the Botox wasn't injected in the right position, which maybe suggests why some of the studies previously published show no benefit of Botox. So I have to say, in the rare circumstances where I am injecting Botox, I really jam the needle into the LES or the pylorus to ensure that it's intramuscular and not in the submucosa.
So you can see here, we're starting to cross the area of the pylorus now. Helmut did a really nice job of angling the scope, and I feel like this is the backside on the duodenum here.
Yeah, exactly.
Just want to open it up maybe just a tad bit more before we start doing the myotomy. What do you think?
Yeah.
Just a tad. But,
yeah, this is where you have to make sure you have injection on that back wall. The real key is you start to see that submucosa of the duodenum undermine behind the pyloric ring, and that kind of tells you where you're at.
Careful, not here.
It's all. It's almost
Sham and Helmut, we're gonna switch to room 16, and then we will rejoin you shortly.
Okay, sounds good. We'll see you shortly.
Can we get the case presentation, please?
All right, case 15. This is a 71-year-old male with a history of decompensated alcohol-related cirrhosis, MELD score of 16. Decompensations are manifested by ascites as well as portal vein thrombosis. A patient who had GI bleeding secondary to fundal gastric varices. Patient was evaluated by interventional radiology and deemed not a candidate for TIPS or BRTO. Referred for EUS-guided coiling and/or glue insertion into the gastric varices. Here you can see a schematic of the Sarin classification. Based on the patient description, I think we're talking about IGV1 varices in this situation. And you see an image to the right there showing the nest of varices. So we are there with Dr. Binmuller. Ken, can you hear us?
Yes, I can. Can you hear me?
We can.
Good. Excellent. That's great news. So here you can see the endoscopic view. This is the echo and curvilinear array. I usually use the diagnostic. There's no need for a therapeutic, a larger channel, but that's what I have, and that's fine. I had started, and I always do, with a gastroscope, so I can retroflex without a cap, by the way, so I can retroflex and really see the fundus well. And he does have fundal varices, and he in fact has a fibrin clot over one of the varices. He recently bled. He's been having melena, so but fortunately not actively bleeding now. So you can see now as I rotate the echo endoscope towards the fundus, sometimes you'll actually see the fundal varices, but at other times you may not. What's key is to orient yourself towards the fundus and to fill the fundus with water. So I've done that. So now we can switch to the EUS view. So now you can get EUS large, and maybe I can have the across from me, the EUS, and then the endo on the left side. So he's got massive ascites here, which is always nice because you see the wall very, very nicely, and it helps you then distinguish varices, which are intramural, from collaterals, which are extramural. So what I'm doing now is I'm pulling back towards the GE junction. And let's mag up just one level, please. And as I pull back, you're going to start to see the varices here.
Is that good?
Yeah.
Okay.
Perfect, yes. So here, look at that. So the water filling of the fundus is critical to be able to define the fundal varices. So now this is actually a transcardia view of the varices. So that would be what you're looking at here. And what I would ideally like to do is to find the feeder vessel. And so to find the feeder vessel, I just slowly pull back. So here you see the cruce muscle there, right? So it's a fibromuscular structure. And I'm going to pull back and see whether I have enough water to be able to look at the fundus. So here's the fundus down here. It's filled with water. You see it? So now I'm looking transesophageal, transcrural, and now you're looking at the feeder vessels back here, and I'm going to look to see if I can target the feeder vessel that's feeding these vessels that are in the fundus. So I'm just sort of turning a little bit. So this part of the fundus is pretty clean. This is deep into the fundus, so there are no varices here in the deep part of the fundus. So I'm just going to slowly go forward. So it's going to be different with every patient in terms of what to target. And I'm just rotating. We can sort of throw on the e-flow here. And I'm looking to see where the connection is. So in real time, just going back and forth, seeing whether this one up here is the feeder feeding these guys down here. These are what bled. Down here is where it bled, probably. Right here is probably where you're going to see that fibrin clot on the tip of this one, because there's nothing actually back here deep in the fundus, right? So sometimes we see that, right? The varices are back here, and then we really have to pull back to the esophagus here to hit it. What I like if we go transcrural is that we have this backboard. So if I hit it, this part here with my needle and inject in there, then it's going to basically, it's that junction between the collateral that goes out here and the varices, which are here. And if I follow this one here, right, where does this go? This is going outside. This is a collateral to the splenic hilum, right? Or you can sometimes see the gastrorenal shunts here. So let me show you how I'm following this, right? Look where the crosshair is. Following, going this way, and boom, it hits here. So this is already varix, this part here. So that's part of it. And then go
Hey, Ken,
further.
we're gonna switch over to Rajan 14 while you finish your exam. It looks like we have some targets there to go after here. We'll come back to you shortly.
Hi, are you there?
Yeah, we're here, Raj.
Tenuous. We're tenuous. We're like, if you can see the fluoroscopy, we're 1 centimeter. Okay, you can start putting the wire back in. We're about 1 centimeter in from the minor. I had to redilate. Very, very tight stricture. It's concentric. As Hiro said, it's a band-like scar. It's whitish. Very benign looking. This is encouraging to me. Would you say?
Yeah,
Yeah.
so I agree with you. So it is it's a really effective examination. So it is this finding is benign. So then chronic pancreatitis make also that's a very tight stricture.
Raj, you are not able to go beyond the stricture, am I right?
No.
No,
We're
difficult.
lucky to be in the across the papilla, but I'm hoping to. What I'm thinking, to Ryan's point here, even though I don't normally do this, but he jinxed me. He jinxed me, Ryan, because I think that what we're gonna do. Wait, irrigate here. is get the wire back up and then actually do brushing. Oh, shoot, 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 shoot. Okay. But it looks very benign. But I think we should at least do a brushing, and then we're going to put a prophylactic stent in. Does that make sense?
Yeah, absolutely, Raj. Can you just tell us what type of stent you're thinking of placing and what the next steps will be?
Yeah, I think we'll wait for the final on the FNB and on the brush cytology we plan to take, and then place a stent, probably like nothing, maybe 5 French stent, just across there as prophylaxis, and then yeah, that's it.
And Raj,
Just
let's
all in a
assume.
day's work. Oh, hey, look at that. Better picture. Okay. Yeah, all right. Okay, thank you, guys.
All right, we're ready to go back to 16, please. Thanks, Raj.
Ken, we're back with you. Can you hear us?
In the esophagus now, I'm going to go transcrural. This is the cruce muscle, right? So it's the the left
Yes, you talked about
arm of the right cruce muscle. It's the right cruce muscle and the right arm of it.
He just wants to flush with saline through the needle.
Ken, can you tell us a little bit about what your plan is? Is this going to be coil and glue, just embolic, just coils?
So what I do is I always do a hybrid. So I will first put the coil in there, and the idea is that the coil acts as 2 functions. It primarily as a scaffold to hold the glue so it doesn't embolize, but it also decreases the flow in the varix, so that also decreases the risk of embolization, right? So it's just slowing things down, the flow in the varix, and it's going to hold the glue, retain the glue where I inject it. So the coil goes in first, and then I follow immediately through the same needle without moving its position with the glue. Now in this case, and I've never used it, but
We're throwing him into the ring here.
you're using gel foam. So I'm open to trying gel foam. Why not? The only issue I have with gel foam is it's biologic. So it's I think of it as being more temporary. And I know the glue, when it solidifies, that's like porcelain. That's hard. That is not dissolving. It'll get extruded like a foreign body, right? So actually, the coil and the glue get extruded from the varix as one piece. We see that on follow-up. So now I don't know really what happens with gel foam and whether the patient is at risk for bleeding later on when that gel foam starts to dissolve. And if you look at the studies, the bias of the studies is that the operators packed the varix with coils, and they injected contrast to make sure that there was no ramp off, right?
Yep.
And then, so you really don't know how much of the success of the procedure is just the coils. What's the added benefit of putting the gel foam in there? I just put 1 or 2 coils as a scaffold and to slow down the flow. All right.
Why are you
now
using
let's
gel
have
foam?
the nurse come over. Now we're going to take this off so that I can introduce the. So we've got the water.
Careful, guys. Can we cap this? Yeah. We
Yeah.
picked a feeder
So
vessel.
the
We're
feeder
gonna go
vessel. The reason is because I want
Ken,
to
can
block
you just
off the
mention?
exit.
Ken, I'm sorry to interrupt. Can you just mention why you're using gel foam? Because a lot more data
No,
on
just because
different types of
that's
glues.
what they use here, and I'm always open to learning new things, so I'm fine. I do use Dermabond, or actually I use Exofin now because you don't need a filter needle to draw it up, and it's cheaper. So it's the octyl 2 cyanoacrylate. That's what.
Okay.
So it polymerizes much more slowly compared to the N-butyl 2 cyanoacrylate, which is the the histoacryl, or the Indermil is the other brand name for it, which polymerizes very fast. So by using the octyl 2, that polymerizes about 3 to 4 times slower. So you have more time to inject, and so you don't have to inject. It won't clog in your needle as you're injecting. That can happen when you use the Indermil or the histocryl. So we don't use that anymore, And I feel that you have to inject so quickly that the stream of injection promotes the risk of embolization. So the idea of the Octo-2, the Dermabond or Exofin, is to just drip it in there and let it then attach to the woolly fibers of the coil. So that's how I sort of think of this working.
Thank you.
Yeah,
yeah.
we
Right.
use the same thing. I think one thing to keep in mind, to Dr. Binmiller's point is, you want to give about a cc over 15 seconds. You want to go at kind of a relatively slow pace to get the cyanoacrylate in there. Ken, when you use the coils, are these coils going to go intravaricile, or are they going to be embedded in the
Totally
wall?
intravaricile. Yeah, totally. I mean, not really, if you can avoid it. It's the idea is for
It's
them
gonna
to
target here.
deploy inside. You see, we don't know exactly where that fibrin was. It this guy here? Was it him? I'm trying to show, or was it one of these down here? If I decrease the mag, you can see it. So this is sort of what you're looking at when you're in retroflexion. You're looking at this and this. So I'm not 100% sure, but this is the feeder. This is feeder. This feeder goes in here, this guy. And then where does it go next? There. It goes over here. And then it goes here. See, it's all communicating. So now if we go back to the feeder, where does the feeder go? The feeder goes back here to the splenic hilum. See? So what I'm trying to do is I'm trying to close the exit so that if any of that glue after you inject it does escape, I've got a gate that's going to prevent it from embolizing into the systemic circulation. All right. So then I will go back here. So now the next step is I have multiple assistants, and I'm going to ask one assistant to hold the scope.
I can do it.
In this position. That'd be great. Thank you.
Do you want me to come on
Anna.
your right or your left?
Okay. I think maybe here over here. So the idea is I'd like to get it where I have kind of like right where it makes that bend.
Here, this
That
bend?
turn. Yeah. I'm going to try. Yeah, it's moving. And then the first thing I'm going to do is just I'm going to make sure that that sheath is out. So this is the cooked needle, but it does have a plastic sheath, not a coil sheath. So you have to be careful when you push it out that you don't push the needle out inside the working channel. So I pushed it out and then kind of lost that now. So let me find it again.
Push in a little. I think there it is.
Here we go. Yeah, here.
What'd you say?
Here we go. Right here. Hold that. Okay. So we have to see where the trajectory is, right?
Yeah, hold on one second. They're gonna calm him down a little.
Ken, these are fantastic views. Just a quick mention on your coil size that you choose in relation to the Barassi.
I'm sorry, what?
Just with regards to choosing what size coil would you use in relation
so I
to it?
measured out the size. Well, something I'm going to actually try because you don't see this maybe on the room view, but this is like all coil.
Yeah.
Maybe
If
what
we
I can
switch
do,
around,
I know.
yeah.
So I'm going to see if I can just
Torque the
rotate
other way.
myself all the way like this.
Yeah.
So that everything is a little straighter, right? Then it's going to be easier, I think.
Yeah, that's the same bend, right?
Right. So now I'm kind of
Yeah.
I'm looking at this screen now, but at least you see my shaft is straight. So I don't have that big loop there because it's kind of harder to stabilize.
Let me know if you need me to come
All
on
right.
that
So
side.
now we'll just have you hold the scope though.
I'm gonna
if you
come
can.
on the other side. Watch out, Blake. We can hug together here, Christy.
So what I ideally would like is to be able to go through the cruce muscle if I can.
Hold on.
1 second. Because that cruce muscle.
Maybe I can ask you
creates sort
while
of
they're doing that.
a
What size
backboard for
coils
me.
would you do? How do you choose the size of the coil?
I'll
I was
measure
always
the
taught
size.
to choose a coil that was about 1.5, 1.25 to 1.5 times the size of the vessel you're going into. And I've seen people do it both ways where they put entire coil into the varix, or also people who kind of start to deploy the coil across the varicile wall to anchor it.
Hold on.
I don't know if there's any data to suggest that one is absolutely better or worse than the other. But typically 1.25 to 1.5 size.
Yeah. And Ken's mention about creating a scaffold is obviously the ideal. How many coils are you deploying, and how do you choose to what the number of coils and the length of the coil?
Yeah, I think that's dependent. I think that's kind of up to the endoscopist. What I would say is that there's people who use maybe an only coil strategy. It's going to take a hell of a lot of coils to close this down. It's not going to be just one or two if that's your only thing. So I think that the ability to use glue over the top of the coils allows you
Okay, inject some water. I'm
to
gonna look
do
for the
less
bubbles. We
coils,
just
and then the
inject.
embolic kind of
Okay,
sticks
we're
to
in.
the
Yep. All right, now we
sticks
do
to the
coil in.
fibrils of the coil.
So Ken, can you tell us exactly what you're doing right now?
Yeah, so I'm in the varix, right? I'm right where it makes that knee, that curve. So the feeder is on to the right. The varix is to the left. Do you see the bubbles? I used to aspirate for blood, but I don't do that anymore just because the blood is always a problem. It starts to clot, and then there's more friction. And then sometimes it's hard to push the coil out, especially if you have a longer coil. These are 14, so it's going to be a longer coil.
So if you see the bubbles, you're good. That's all you're doing.
Exactly. So now we're just going to push so we're basically advancing the stylet, right? Is that what you're advancing to push the coil
Out of the way.
forward, right? Yeah. Okay. It's already inside, yeah. So you already pushed it inside of the needle itself. You remove the delivery catheter, the loader, and then you'll see it come out in a moment. And that's all under vision. You may adjust the position of the tip of your needle accordingly.
There it comes.
And there it comes. And just let it just unravel right in front of you. And I'll pull back a little bit, just let it unravel. There it goes. See, it's circling, circling, circling. And I want it, to have a few loops. It's 4.5 loops, by the way, right? We're 14. All right. So now we're in, and now we can follow with the glue, or we could put another. If it were bigger, I'd put another coil.
Okay.
No, I think it's fine. It's packed enough. I looked at how packed it looks. And sometimes these varices are quite big, right? 2 centimeters. Then I got to put more coils in until it's really packed. So we're going to use the gel foam. All right.
2 cc's.
Good. Yeah, do that.
Is that how much glue you'll use? Same volume?
Oh, I always say aliquots of 1 cc.
1 cc.
Yeah. And it's just dripping it in. We can also use the Dermabond if you want, but I'm interested in seeing how this looks.
There we go.
Okay, you see it going in there. What I like about the glue is that when the glue goes in, it is like white, right? The whole thing is just white, and I know I'm good. Is that enough? Okay, then do we wait until the Doppler's gone, or what do you do? Do you want to put another in there, or no, another gel foam? Because I still see Doppler.
Yeah. Ready?
It's all about
different types of fluids.
So you put more coils until the Doppler goes down more?
Which is exactly the first point that you had made before, right, with the study?
I mean, I think that the problem for me is just that the rationale for the coil is a scaffold to hold the glue. Now we got gel foam, so it's sort of, okay, having it stay on site is maybe not as critical. And I don't know how much of that gel foam attaches. Cyanoacrylate is a glue, right? It's crazy glue. So it glues and attaches to the coil. Gel foam is not a glue. I don't even know if the gel foam's attaching to the coil, right? So,
I mean, some of this is just artifact from the needle tip, don't you think, as opposed to true flow?
So maybe stop here. I mean, look, I've never done this, so you tell me what I should do.
So maybe I can ask the panel, what do you use with your histo or acryl to prevent it from solidifying in the needle?
We don't. You can use Lipiodol. We don't use anything. We just use straight glue.
Okay. Yeah. So we
Here's the Varix right
we
here,
struggle to
see?
get
I'm
Lipido,
just
and
rotating
so
a
what
little
we
bit
actually do
here.
is mix it with propofol, 1-to-1 with propofol,
I'm just gonna
and
try
the
to
Yeah,
lipid
do you want
nature
to
of
rotate
propofol
it
prevents
down?
it from clotting. It's
counterclockwise.
fantastic.
So as I pull back,
Yeah,
what
so
I
it's
see though is
What's
that
the,
feeder
if you mix
vessel
the glue with
is
propofol, what's the
still
ratio?
1-to-1. Yeah,
there.
I mean,
Going back. Why don't
there
you
is a
There's no
there is a
magic.
variance
inject some
really,
saline,
but it's more or less
right?
1-to-1.
And that's the feeder
Um,
right there that you're looking at. I'd like
Yeah.
that guy to be occluded,
You're
to
gonna
be
do another
honest.
coil
Yeah.
in there?
Yeah, we mix it with the
Yeah.
Lipidol
No,
because
just
we
put
get
some
it from
saline
IR.
first. I want to
So
confirm,
we
Eileen,
mix
that
the glue with the Lipidol,
and you'll
which is
see the
basically like
bubbles
an oil,
if we're
because
in.
we get it from IR and it comes in the package with the glue
Yeah,
and
see,
the
again, it's
Lipidol,
in the
and we
feeder.
mix
So
it
let's
in
put
two to
another
one.
coil in.
Yeah.
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 Okay,
And then
good.
the other medium that you can use is
Another coil.
5% or 50% glucose.
So the
So
feeder is
that also
really
prevents it
important because
from
if you
clotting.
get the
Yeah.
feeder, I'm going to show you when you look at those other
Just for the
varices that we
audience, that's
saw
all
earlier,
to make sure that the
they
glue
will
doesn't crystallize inside the
there'll
needle and
be
clog it.
sluggish flow in them, and
And
they
from a
usually
technical
lead to
aspect, what we
thrombose.
try to do
In
is
other words,
actually
you don't
place
have to inject
the
those
ideally
other
we were just
varices
discussing what is the ideal
separately.
number of coils,
If you just
but
hook
it's
it up
very
to the
difficult
feeder,
to
you're
place a
done.
coil, then place your histone acryl glue, and then place another coil. Regardless of what you're using to prevent the clotting of the glue in the actual needle sheath, it does. And placing that second coil is very difficult. So place the number of coils that you deem necessary to create the scaffolding before you insert the first histrel. That would be our experience. Yeah.
And do you have
Hey,
any tricks?
can you just tell us exactly what you're doing? Sorry, we're a little lost right
Drawing
now.
it up.
Yeah,
You
I
need
get it
a
down.
special filter needle,
Uh-huh.
and just draw it up, and draw up 1 cc.
And you have no issues when you have your assistant injecting it? We've had some
No,
issues
no, it's
pushing it
very
down.
easy.
Okay.
They hate the Indermill because
Yeah.
it's so, you have to inject it so fast.
Sure.
But this is you drip. We literally look at it dripping in there. You see the Octo 2, the Dermabond or the Exofin. You see it attaching to the
Scaffolding.
coil. Yeah, so it's really, to me, it's so convincing.
Here comes the coil.
There's comes a coil, and there, see, it's
There
going
it
where I
is.
want it.
Yeah.
I want it in the
Towards the
feeder.
spleen.
Yeah,
There you
that's
go.
where I want it. Beautiful.
Hey, Ken, this
Okay,
is Ryan.
now immediately follow with the, we'll use the glue now.
For IR people would have more experience. So if they use
Ken, can you still hear us?
You can.
I have a quick question. So with that first coil in gel foam, if that kind of slams the door at the downstream Varix, what's the benefit of placing a coil in embolic behind that one?
Well, because the original one didn't slam the door shut. The door's still open.
Well, you can
You
see, you
saw
can,
the feeder.
yeah, but
That
do you
one is
see,
not,
do
that
you,
one
do
is
you see
not shut.
anything back towards the fundus? Or you haven't looked back towards the
Yeah, I didn't
fundus?
really look, but I didn't feel that I really closed off, the faucet to the fundal varices. If you shut off the faucet here, you slam this door here. And so the other thing is we have this perception of afferent versus efferent. It isn't that way. There's not like one goes in one direction and the other goes in a different direction.
Ken, there was a beautiful demonstration. We're going to go to room 15 to watch Dr. Messman complete the myotomy, or if it's already completed.
We're about to do the myotomy.
Okay,
We've been
perfect.
we've been having a little bit of issue though with this case. It's
I'm
actually. Go ahead, Muhammad.
No, I'm struggling. I'm struggling
and
because
actually
there's
some
so
people
many
would
fatty
just
tissue,
before
and it was even at the
Yeah.
pylorus, so I had to use a snare
Yeah.
to remove the
Yeah.
fatty tissue.
You guys actually see this submucosal bulge here? There was an actual
We'll find other
lipoma
ways to
in
do
the
it.
tract that we ran into that we had to resect.
Lipoma?
So now it seems that we're at or near the pylorus. It's just the scope position's a little bit challenging, but Helmut seems to have gotten into a good position now to initiate myotomy.
Huh.
There you can see the ring kind of just.
Yeah. My aim is to cut more to the 3 o'clock position. Yeah, you see the ring more here, but the scope is really twisted for some reasons, and here you have this fatty tissue I had partially removed. I have partially removed with a snare. Otherwise, I couldn't find the ring, and the scope is not stable.
No, we found the ring. We're just having difficulty with our scope positioning. So, any thoughts from the panel? Any recommendations what we should do?
Dr. It's not going to suction if you have the device in there. I would take it out, suction.
Sham, do you think using something like an IT knife to just kind of drag instead of trying to use the TT knife, would that help?
Yeah, I think. Go ahead, Helmut. What were you saying?
No, the problem is.
You can see the blue on the duodenal side, actually, if you go back there. Yeah.
No,
yeah.
we have nice bulge here, no? So we really know, and there's no damage of the mucosa here, and now I can easily pass. So at least we have not dissected the ring completely, but some muscle fibers. I'm not happy with the position. This is my main concern, and you see here it's twisted. Yeah, you see. I mean, I can cut here and look what is the clinical success. Yeah, this is a ring. This is a ring. So
yes. So he's having difficulty getting in the knife into that position in a stable scope. We can certainly use the IT knife. I think it's a great suggestion if Dr. Helmut agrees.
Yeah, we can do it. We can do it.
Helmut, any benefit to rotating the patient, you think?
Yeah, I was wondering, indeed, yeah. Perhaps we put it a bit on the left side. Perhaps we can put it a bit more to the left side, lateral position.
Yeah. Can we try and get her in the left lateral?
Yeah. Let's try first the position on the left lateral. Yeah.
Yeah. Belly is nice and soft. Patient's doing well.
His belly is nice. My belly is nice. Yeah, struggling here, struggling. But we will find a solution.
So I think this shows like how important it is to always maintain your landmarks and really let that guide you in order to do an appropriate myotomy. You can see how easy it is to potentially get lost and how a short distance can still be quite complex. And I think that just kind of this case is kind of highlighting that. And so some troubleshooting measures like you guys are describing can hopefully help us solve the deal here.
So I'm going to go.
Yeah. Yeah. Good.
Might be a good idea. And then always decompress the stomach. Sometimes also.
Yeah.
We're going to go to the lecture now. Okay. Hey, Sham and Helmut, while you work your way through the myotomy, we're going to go to our lecture this afternoon, which will be given by Dr. Alan Barkan. Alan is a dear friend who was the chair in gastroenterology and professor of medicine at the McGill University and the McGill University Health Center in Montreal. And he will be speaking to us this afternoon about blood, and more blood, GI bleeding in 2025, tips and tricks. Alan, thank you for being a part of RMIE this year.
Thank you very much. And again, thank you for the invitation. Hello again, everybody. For those of you who were here yesterday, hello again. I've been asked to take about 15 minutes to give you an update on GI bleeding. I'll try and do my best to lead you forward through this. So we're going to talk about non-variceal upper GI bleeding. As you know, the mortality, we used to teach the mortality was 10%. It's actually down. It's now well shown it's about 2% or so based on most registries. Peptic ulcers remain the most common cause of non-variceal upper GI bleeding. PPIs, as we know, are supposed to be considered an adjuvant to successful endoscopic hemostasis, which is the cornerstone of management for these patients. And I'll spend a little bit of time more talking about hemostatic powders and cap-mounted clips because that's where the new literature is coming from. So let's try and put into focus, but I will give you an overall view as well. I remind you that of all the patients who present with GI bleeding in the emergency room, we suggest using the Blatchford scale with a cutoff of 1, which means if the patient has melena, they can have nothing else, no comorbidities, no instability when they come in, and no anemia. So very limited number of patients, but it represents a significant proportion who can actually be sent home, and you can actually scope them electively and not have to keep them in the hospital, let alone admit them to the hospital. And the negative predictive value is under 1%. So it's very, very helpful from that point of view. I did want to share with you, I don't know if you've seen this or not. This is a study from Mayo, something called the pill sense. So it's a capsule that the patients are given to swallow in the emergency room, and it comes out as yes or no, very easily interpreted by the emergentologist to know whether there's actually presence of blood or not. And I think what we're going to see over the next couple of years are studies looking at, we know for Blatchford that these patients can go home if there's less than 1, but with an intermediate Blatchford score and the patient is still doing well, is this also helpful to try and send some patients home as well? So something to look at for in the next few years. Now, I'd be remiss if I didn't remind you the timing of endoscopy. We're told that the perfect GI paradigm is the patient's either too stable to come into scope in the middle of the night or is too unstable to come into scope in the middle of the night. Well, the data actually suggest that that's the correct approach. And I'll just go over it briefly with you. This is a large cohort study looking at patients. If you look at those with ASA scores of 3 to 5, you can actually see that there's a U-shaped mortality curve. These are the sickest patients we see, and you actually have increased mortality if you try and take the patients to endoscopy within the first 12 hours. And that presumably represents people who are inadequately stabilized hemodynamically. So you should never feel bullied into going in because the patient is so sick. You need to go ahead and do that. This is incorrect way of proceeding. Okay. And I'm happy to discuss it with you further if you want to. We can discuss massive transfusion protocols. We can discuss an upcoming survey that will be published in Gastroenterology, highlighting that we're not sure completely how to identify these patients, but beware. First, do no harm. The unstable patients need to be stabilized. And then, following the first 12 hours or when semen is stable, anytime within the next 24 hours is fine. That is good for you. Past 24 hours, the mortality starts going up again, and we've known this for a long time. Additional data to show very, very sick patients. This is a Lao study of Hong Kong, Blatchford score over 12, very sick patients. They were randomized to the usual early endoscopy within 24 hours versus what's called an urgent endoscopy within 6 hours. The patients represented, we usually see mainly ulcer bleeding, about 10% varices or so. Look at the time to endoscopy. This shows you that real life. This is a randomized trial. So the urgent patients who were supposed to be scoped within 6 hours were within 10 hours. But look at the control group. We say within 24 hours, this is a mean. So you have up to half the patients who were scoped past 24 hours, to give you an idea. And these are the sick, very sick patients, Blatchford of 12 or more. Over 500 patients, no difference in mortality, no difference in further bleeding. The only difference is if you scope them earlier, you end up getting more high-risk lesions and more endoscopic hemostasis. But this does not translate into improved patient outcomes. So again, important data to keep in mind when you're speaking to the emergentologist or the intensivist or the surgeon or whoever's calling you in the middle of the night. Okay, there is no data to suggest that you should go ahead and come in earlier for these patients if they're not hemodynamically stable. In fact, the contrary. Very briefly, prokinetics therapy. I remind you that infusion of erythromycin is helpful. Not only does it decreases the need to go back a second time to see where the bleeding is coming from. It improves mucosal visualization, and particularly in patients with varices, it decreases duration of hospital stay. And for those of you who've been talking about metoclopramide, I can now say there are data to support metoclopramide as well, rather than erythromycin. These can be given anywhere from 45 minutes or so before you go in and scope the patient, primarily because of improvement in visualization. That's the improvement in these. Now, if we move on to endoscopy, so how to treat the patients. This is from the ACG guidelines from 21. We look at bipolar electrocoagulation, clearly very helpful. Heater probe and injection of absolute alcohol, particularly done in Asia, are all very good, very strong data, the best we have in GI bleeding. Through the scope clips, APC and soft monopolar electrocoagulation. There's less good data, but nonetheless enough to recommend using them. And I remind you that using epinephrine injection alone should not be done unless you're practicing somewhere where there's nothing else available. If not, it should be done in conjunction with, or rather use another modality if you're going to use a sole modality. So this is background. What I'll try and show you here is the couple of tips for you. So this is a patient. If we can go to the first minute of the video. Okay, great. Thanks. I just keep going forward. I just want to move forward for you, but I can't alter the video here. Keep going, keep going. So what you can see here, and keep going, please. You're going to see at about noon or so, the presence of what is a de la foi lesion. So there's no actual abnormality in the mucosa, but there's actually pumping of the blood. We stop there. Thank you. If you can have a look and see. I think you're keeping, the video keeps going back to 0 every time you stop it. Can you get it frozen at that level? Okay, yeah, just run it from there. Thank you very much. So if you look, you'll see at 11 o'clock, there's oozing present there. You can't see it quite as well now. And this highlights a couple of things. When you're doing an active bleeder, you must position yourself in a place so that the blood won't impinge your visualization. You can see the pumping in that area. And so the clips, as you know, if you're going to use clips in the middle of the night, the person helping you needs to know how to use them. You need operative words. You need to know how to use them. You can see here that the clip was positioned. Most clips you can now close and reopen. Unfortunately, when it was closed, it was still pumping. And then they went ahead, released the clip, and what you have is still pumping. If you can move on to minute 2 of that video, please. Just move forward. So rather than crying and saying, oh, I missed your chance and so on, the idea is you're going to use that clip to give you an idea of a mental image of where you were so that you can go ahead and position the second clip. And that actually allows you to actually support it as well because it's an awkward position to be in. At that point, we actually went ahead, saw that there was no bleeding. See, we could close the clip, no bleeding, and went ahead and released the clip. And there you have. And can you go to minute 3, please? And subsequently, the patient did well. But these are to highlight points when you're going ahead and using your clips. You need to know how to use them. You need to close it, see if, in fact, you stop bleeding. And again, position yourself appropriately. Stop bleeding here, and subsequently we went ahead and did epinephrine injection as well. You do not need to do epinephrine injection in addition to clips. If you are going to do it, you do clips first and then injection. If not, you risk having the edema that disappears after the injection, and the clips might fall off. So although the data suggests that clips alone is fine as well. Okay, thanks. If you can go to the next slide for that. No. Okay. A common question is asked of us is second look endoscopy. There is no role for routine second look endoscopy. The data are here, almost 1,500 patients, randomized trials, although many are old. In the newer literature, in fact, it shows that there's no benefit attributable to these, particularly in the era of PPIs. So you go and do a routine pre-programmed second look, which means you scope them 12 to 16 hours after you did the original endoscopy, only if you feel that you haven't done a job that you feel comfortable with. There's no need for routine second look in any of the patients. Sadly, endoscopic Doppler probe, for those of you who know how to use it, is amazing and probably helps. This is data from randomized trial data that we don't have much of it. This is from Dean Jensen's group. And what you can see is that this was the data as when a patient, you actually look versus using a Doppler. And if you actually go ahead and use a Doppler to decide on the outcome following endoscopic hemostasis, you can see that actually you get a better outcome with regards to decreased bleeding if your outcome point is driven by a Doppler. And it makes sense. Despite randomized trials, despite meta-analyses, the Doppler technology is used almost nowhere and is very simple to use. We've actually done not 1, 2 cost-effective studies showing it's incredibly cost-effective. It's not that expensive. And it's a mystery to me why people don't use it more frequently. I'm just mentioning it to you. It's a shame. And the guidelines actually, unfortunately, haven't gotten to tackling that particular issue, but it is helpful. And there's even 1 new randomized trial since the meta-analysis that has been done that suggests improvement. Now, this is a brand new guideline we just published 2 weeks ago in gastroenterology. You may have seen it. This actually tackles an issue and has been sponsored by all the major GI societies globally, including from North America, Europe, and Asia, as well as the World Gastroenterology Organization, looking at non-variceal, non-ulcer patients. So I'm just giving you the take-home messages. In patients with active bleeding from malignant GI tumors, topical hemostatic agents are indicated. In patients with active bleeding from Mallory-Weiss tears, either endoscopic band ligation or through the scope clips. And in patients with non-actively bleeding Mallory-Weiss stairs, we suggest against endoscopic hemostatic therapy. So the recurrent bleeding rate for Mallory-Weiss stairs is very low. If your patient is not bleeding at the time, you actually don't need to do anything about it. With regards to deux la fois lesions, you can use mechanical devices. You can use as well with or without epinephrine injection, and you can use sclerosants or not. So whatever you prefer using in that context. For GAVE, this is relatively new, may surprise some of you. We recommend band ligation over APC. The data suggests that it actually more quickly helps resolve the issue and decrease need for blood transfusions in follow-up on time. And we suggest against radiofrequency ablation for GAVE. So these are new guidelines. You'll hear more about them if you're coming to the ASG postgraduate course, and you'll hear more about it with your different meetings coming up. Okay, having this in mind, over the last few slides, what I'd like to do is spend a couple of minutes on the newer technologies that you may have seen and heard a lot about over the last 4 or 5 years. So the patients who are refractory, with whom there's increased risk of bleeding, include people presenting with hemodynamic instability, active either bleeding, spurting, or oozing, large ulcers, and ulcers that have that bleed from vessels that have names of arteries in textbooks. And that includes posterior duodenal ulcer and high lesser curvature. For these patients, we recommend a repeat endoscopy with the same modalities I told you about, but this is what pushed people on to try and find additional approaches possible, although, of course, transarterial embolization remains a possibility for these patients. So let's first talk about hemostatic powders. This is TC325, but the mechanism, although the actual compound varies, the mechanism is quite similar. The granules will stick to the bleeding site, will absorb water, and you get a tamponade mechanism stopping the bleeding. Very helpful. The problem is that the resting time is 24 hours or less. So their patient is at risk for rebleeding if you use this alone. Nonetheless, we did recommend using, in this case, TC325 hemospray, which is by far the one that's been studied the most for patients who have active bleeding ulcers. There's a non-inferiority study that was shown by the Hong Kong group, clearly showing that it is non-inferior to other endoscopic methods. Although there were some methodological issues with that study, the problem is the cost, which is extremely high. So although it is cost effective, it's much more expensive than many other approaches. What I want to show you here is moving on using the powders for malignant bleeding. I told you it's now recommended. I'm going to explain to you why. So this is a patient who has a huge cardiac lesion at the G junction. You can see, and it highlights all the issues with malignant bleeding, a large surface area, very friable tissue, and multiple bleeding points, which as soon as you touch will bleed some more. So the advantage, at least theoretically, is that you can go ahead and cover a large surface area with the powder throughout, and without actually touching or causing mucosal damage, which at least theoretically people theorized that it would be a helpful approach for malignant bleeding. And indeed it has. And what I'm showing you here, although there have been numerous data, we just published this in the Red Journal. This is an individual patient data meta-analysis. There are only 3 randomized trials in literature, but when you use the individual patient data, you actually get the really very helpful information. Immediate hemostasis, an odds ratio of 47. It's 47-fold more likely than anything else to stop the bleeding on an immediate basis. Further bleeding is actually improved both from an immediate hemostasis, and 30-day rebleeding is improved as well. Now you're going to ask me, I told you that the spray stays on for 12 to 24 hours. How can that improve bleeding from a cancer that is still there a month later? The answer is nobody knows, but both data from North America as well as from Thailand and from Brazil have all shown the same thing. And the theory is that when you stop the bleeding acutely, you may be able to decrease DIC that is occurring locally in the surface area, and that has impact with regards to stabilizing lesion and decreasing rebleeding even at a distance in time. And it's been shown to be cost effective. The last point I want to show you is the over-the-scope clip, and I thank Amrita Sethi, who's actually here in the room for this video, and just to show it to you, I think it's very nice. It's certainly the nicest video I've seen to illustrate a point. So you're all familiar with the cap-mounted clip. I won't go through this. This is a patient who had bled from a duodenal ulcer, bleed in the bulb, was treated endoscopic hemostasis, rebled, then had coils. Can you see the coils present here in the base of the ulcer bed? That gives you an idea. The patient then rebled again. Bear in mind what I told you, this is one of the areas with the pancreatic duodenal artery where you can have recurrent bleeding. And indeed, this patient rebled. And at that time, the patient was brought back in for an attempt at using cap-mounted clip. So as you know, you can do it either by grabbing the whatever lesion you're doing and then trying to pull it into the cap, or you can try and suction it. The grabbing it did not work. Then they'll suction and you'll see how that will proceed. So the advantage here is that you get a transmural bite, which allows you to be able to go ahead and to actually get rid of the bleeding site per se. And you'll see how unstable the lesion was at one point in time here, just by suctioning it. You can see it starts bleeding very actively, which is quite obvious as to what the problem was and why the patient kept pre-bleeding. So that gives you an idea. The cap-mounted clip was actually delivered successfully. The patient stopped bleeding. And in fact, at the end, you can actually see that the actual coils are even closer to your endoscopic image, highlighting the fact that it is a transmural bite throughout the muscle wall that has occurred. You can see the coils present again here. So what about these? They are recommended for recurrent bleeding. Small randomized trials show that this was the way to go, and that we've known for a while and has been shown to be cost effective. But more recent data looked at using cap-mounted clips as initial treatment. It's been now shown in 5 randomized trials that it helps with regards to the 30-day rebleeding. So if you can put the clip on, it actually will help and will allow you to decrease rebleeding, which is why it's been suggested. The problem is that there are a number of issues with it. I'll skip the methodological problems for you. The main problem is we do not know which patient anatomical factors are best to help decide who would benefit from a clip, a cap-mounted clip, and who would not. It's unclear. You'd think it's large ulcers that would benefit. There was one study that was done, only looked at those. It was a negative study. So that's unclear. In addition to that, the endoscopists need to know how to use it. And finally, you have a 2% complication rate, which is higher than many other approaches that we use. Finally, just to remind you, high-dose PPI therapy for 3 days, high-risk patients will benefit from twice-a-day PPI therapy. And you may have seen the study just published in Gastroenterology. Vonoprazan can now be used post-successful endoscopic therapy as well. I remind you to test and treat for HP, secondary prophylaxis PPIs, and oral iron replacement, all of which has been shown recently in randomized trials to be helpful. So in conclusion, the risk scores, perhaps new technology will help us better even define who should or benefit from going home and coming back to have an elective endoscopy in the acute setting. The timing of endoscopy, as I've mentioned to you, we've talked about thermal sclerosant clips, the hemostatic powders, as well as the cap-mounted clips. I've reviewed very briefly with you the non-variceal, non-ulcer lesions, and the rest remains as to what we usually do so far. I know it's a very quick turnover, but we only had about 15, 17 minutes to go. So I hope that's helpful for you, and you're welcome to come and speak to me afterwards if you have any specific questions. Thank you for your attention.
Thank you so much, Dr. Barkan. That was a fantastic presentation. We're ready to go live, and we're in room 15 with Dr. Messman. Helmut, can you hear us okay?
Yeah. Can you hear me?
Yeah, we can hear you. Not that clearly, though. Okay.
I've completed a myotomy. Can easily pass now the pylorus, and although the tunnel is now, it was a bit of oozing, but now we perform the myotomy here. Yeah, you see 2 incisions.
The myotomy is more at 9 o'clock, which is typically we do it at 6 o'clock because of the angulation, where Dr. Messman was able to navigate it pretty beautifully. So.
And in the middle, you see this tissue. This was a fatty tissue, and I had to resect it with a snare. So now I'm closing the defect. Due to the bulk, it's a bit not so easy to see, but I hope we can grasp the open, please. Yeah, okay, close.
So Dr. Messman made a longitudinal incision.
Yeah.
So that's why using clips. Some people do a transverse incision where in that case, we prefer suturing.
Close slowly. No, open again. Yeah. Open, slowly. Okay, rotate a bit. Slowly.
Did you give antibiotics in this setting, either
yes.
prior to the procedure? What about in the tunnel?
No, we don't. In our practice, we don't do intratunnel antibiotics. If there was a full thickness perforation, like we had seen the whole serosa or something, we could consider it. But even in those cases, I felt that, you know, if as long as you can close it and your mucosal is pretty good, we've not needed to. Ryan, what is your preference?
Yeah, I think antibiotics in general for any of the Pullman procedures, I'm not sure there's ever going to be any data that support
Right.
it wholeheartedly. I don't do it for gastric poem or Zenker's, and for some odd reason, I do it for esophageal poem, but that's maybe out of habit. What would be your standard kind of follow-up protocol for this patient? Do they go home? What's their diet? Do
Yes.
you get upper GI series routinely?
Yep. So we do get an upper GI series, and I think the part of the reason is that in Colorado, a lot of our patients are traveling from 8 hours or 6 hours away. So that makes it you know, a little bit more reassurance to be able to get there. So that's why we don't we'd like to do an upper GI series. There is some retrospective studies where people do send the patient home the same day. But in our practice, we do like to keep them overnight for that reason. Sometimes we are able to do a same day upper GI series, and then we're able to discharge them the same day. So it depends a lot on the factors, where the patient comes from, time of the day it is. If it's later hours, sometimes we don't have our radiology team to be able to do the upper GI series and things like that. So, what about you, Ryan? Or Momin? I guess anyone else on the panel?
So our practice is the same for both esophageal and gastric poems. We keep them NPO overnight, and then next morning they get a gastrographin swallow or gastrographin upper GI series for G poems. And if there is no leak, we start them on liquids and they go home. For the E poems, we bring them, of course, for post-op clinic follow-up in a couple of weeks, but we scope them after 6 months for a Bravo study. And we keep them on PPIs for 6 months until they come back for the Bravo. The Bravo is done off PPIs. And if there is no acid reflux, we stop the PPIs. If they have acid reflux, we continue PPIs. For GPOMs, we scope them within 3 months just to check the healing. I think for some reason we always worried about healing in the stomach more than the esophagus. So we just do like an EGD in 3 months to check the area, make sure it healed up nicely. Most likely don't see anything, but it's just for reassurance.
Do any of you do a gastric emptying study on follow-up at all?
Our motility group will do one at 3 months for gastric poem. We'll do a gastric emptying study and just see if there's improvement. Our practice is a little different. We probably discharge 75 to 80% of all of our poem procedures the same day. We do ask that they stay in town overnight. And then for esophageal poem, we have one of our nurse practitioners see the patient the following day with an esophagram. For gastric poem and Zenker's, we reach out to them and just kind of check in by phone to see where they're at and how they're doing.
So do you guys routinely schedule clinic visits after you do these procedures? Have them fill out any validated questionnaire to see how they're feeling?
Yeah, routinely on the
Right
follow-up
now,
clinic
you can
visit.
see that we're struggling with the clip closure because the gastric mucosa is so thick, and sometimes that's one of the challenges in clips with the stomach. You know, because you can see it keeps slipping off, so that's sometimes a little challenge. So, Dr. Messon, what are you trying to do now?
Bilal, do you think there will be like? Do you think there is a role for something like the mantis clip for
Yeah, that's what
something
we're
like that?
talking that whether we should switch to the mantis.
Yeah.
He recommended the mantis. I show you what
So Sasha, going back to your
what I have learned
We'll
from
wait
my
for them.
Japanese friends.
Yes.
Yeah. So needle out. Then so I make a small hole here, and then I can anchor the clip a bit better. Yeah.
Interesting.
The other thing you can sometimes do in this situation is we're trying really hard to close these tunnels with a kind of a perpendicular approach. If you go very close to the proximal aspect the incision and you take more of a longitudinal approach and suction, you can put a clip across that's almost in plane, and then it closes it enough and raises up the edges enough to get one in between. But the anchoring clip idea certainly a good option.
I typically suture my G-pomes because I make a transverse incision as compared to a longitudinal incision. But there's no right or wrong. I mean, it's
So now open.
Huh? There's no clip there. No, no clip. Clip gun, yeah. That's a used one.
We were just testing you, Helmet.
For some reasons, the clip was lost.
For a second, I thought this is like a new device that we gotta.
Would you keep this patient NPO tonight?
Yes, we do NPO. We're gonna get an upper GI series tomorrow, and then kind of go from there. This is a post lung transplant patient, so we let him have some medications.
Turn, twist. Yeah.
So I think that's an
Not
important point to bring up. We're starting to see more of these patients post lung transplant as well. Our colleagues on the lung transplant service tell us there's a large percentage of patients who immediately post transplant have about 6 to 8 months of gastroparesis. It often will resolve on its own after that time. But I think during the lung transplant, there's often some vagal injury. And I think this is certainly a good option for those patients with the goal of protecting their new lungs.
Yeah. And actually, it's funny, Ryan, you said that. This morning, I had to do a peer-to-peer with the insurance company today for this patient for that same reason.
I'm so glad you did that, Bilal. Do you want to talk to us a little bit about our practice here at the university, how we're seeing these patients in our multidisciplinary clinic?
Yes. So for achalasia patients, we have as you know, from thanks to Sachin, we have a Rady Center of Excellence of Esophageal Diseases, and which initially started the concept of malignant diseases, esophageal cancer, Barrett's, but now we've expanded that to benign diseases. One of our colleagues, Kelly DeLay, directs our benign disease program, and we review a lot of the esophageal achalasia patients in our. This actually looks. Can you insufflate a little bit? I think it may be good. Sorry.
Wait.
I have a hard time with this.
Yeah.
Shut. Fire.
Yeah. Good.
Fine.
Yeah.
Maybe a couple more in the middle. One more in the middle.
Mm-hmm.
Oh, sorry. So there, we do discuss almost all of our achalasia patients. If they're type 3, we don't, but type 1 or 2, a lot of them. Type 2.
Very small clips.
We go to our esophageal multidisciplinary clinic where we have thoracic surgeons, our motility experts, myself, and other obviously our surgeons and radiologists, and we review all these cases and truly offer the patient all the options, and then determine. Obviously, our surgeons are very supportive of our POEM program, and that's what we do for these patients. Yeah.
What is this?
I think that's such an important point, right? Having a multidisciplinary clinic available for all these complex diseases that we've seen all day is so critical. And we're really blessed to work with an amazing group of surgeons, oncologists, pathologists, radiologists, and IR folks. So I think that's a really important point that I wanted to make. I also wanted to open up, Alan's presentation for questions. I'm sorry we didn't get time to ask you questions. So anyone in the audience have any questions for Dr. Barkan?
Got it.
No. Can I?
Yep, go ahead.
Yeah. Can it trend? 3 o'clock.
You stopped them because they had GI bleeding. You pressed them like and you achieved hemostasis. Would you consider doing a rescope when you stop that?
No. But we don't, unless there's a reason that you're concerned that it wasn't done properly and so on. We don't do routine rescoping. And as you know, the ACG guidelines recommend really very little from that point of view. We scope them in the acute setting. We don't worry about it. The only time you should worry about scoping someone who's on any anticoagulant in the acute setting is if they appear super anticoagulated, if there's spontaneous bruising, if they're, as soon as you put the gastroscope, the lip starts bleeding, the gums start bruising, and so on. That's a totally different issue. But it's very rare, as you know. If not, you go ahead, you proceed, you do what you have to do. And for ulcers, it takes, as you know, ulcer lesions, high risk to low risk takes about 72 hours. So for then, you may want to hold off on restarting the DOAC if you can, again, depending on the indications, but as a rule. But if not, particularly, for example, for Malloy tear, the recurrent bleeding rate, GAVE is not an issue acutely. And the others, usually you can go ahead and restart it within the next 36 to 48 hours. Okay? Yep. Yes.
Go ahead.
For malignant bleeding? So
Using a Doppler.
Oh, the Doppler. Yes, yes.
Yeah, so I just wanted to ask you, like, what are the barriers to widespread adoption of the Doppler probes, especially for trainees, because it is a very good objective tool.
I have no idea. I've been doing jab bleeding for 35 years, and I've seen everything evolve. This is one of the things that I cannot explain, and I'm as much to blame as anybody else because I lecture a lot on it. The guidelines never get to it because we always choose other more important quote unquote issues, but it's one that works quite well. I don't have any shares in the company, but I can tell you that the upfront cost of the equipment is about 10,000 or something, or at least used to be, and this disposable is 200. It is incredibly cost effective, and I cannot explain. And, you know, I don't do US, but I can put a probe and see if there's a signal or not on it. It's not that complicated. I think there was not an interest in the company of developing it. And I think that the data that were presented just didn't make enough impact, but I cannot explain it to you. I really can't. To me, it's reasonable, and there are randomized trials. It's not as though the randomized trials should be done to confirm it. I think there's enough observational data and randomized trials now to suggest that it should be done, and cost effectiveness data as well. So I cannot answer that question.
Alan, I do want to congratulate you on your most recent guideline document and getting multiple societies together. I think that's just an amazing feat. I think that's what we should all be aspiring for. I always take any opportunity I can to make that point, that we need guidelines that include all societies rather than having separate guideline documents from different societies. Having said that, Ryan and I were just talking about it, and I had the opportunity to actually handle that paper in Gastro. And one of the comments that Ryan was also making was one of your recommendations stated that the use of radiofrequency ablation, which many people have actually used in their practice for GAVE, is contraindicated, or you recommended.
Contraindicated, not recommended, just because
recommended
the
against
data
it.
was not supportive enough. As simple as that. I would tell you that for GAVE, we had 6 randomized trials. 4 of the randomized trials, in fact, reported, published, never were done, did not exist, were completely made up.
Wow.
Just so that you know. This is something I had never run across before. I don't want to go into details about it because there's potential legal implications. And so that the whole GAVE story is a very complex one, which we had to actually go through and so on. But I learned quite a bit, and we had, when you thank me, you can thank the group. We had amazing methodologists and a number of people from the Cochrane collaboration who are based at McMaster. And they tell me, I hope everybody's sitting down here, that 30% of all published randomized trials right now are made up.
That is so disturbing to hear.
It is. It does come for certain parts of the world more commonly than other parts of the world. And the problem is, I'm not sure why we're discussing this, but I guess you can bill for psychotherapy for me afterwards. The problem is that you cannot say to an author this because they'll sue you. You cannot say this to a journal because they will sue you as well. So nobody does anything, but there are mathematical models that are now applied when we do meta-analyses, where you just run through a number of the outcome measures that are seen and descriptive measures of patient characteristics. And you can find, based on that the likelihood that the study was made up is over 80% or 90% if it meets certain criteria. And that was the case for 4 of the 6. And if it's not written in the large print, but it is written indirectly in the fine print, in the supplements. So just be careful. And I'm just worried that in between that and social media, we were going to have to be extremely careful, and AI interpretation, how we get driven by data in the future. It's very disheartening. Yeah.
It truly is. I just wanted to tell you all that there were so many interesting aspects of all the live cases that we did today that we were not able to show you, right? For example, the case that Colin did, which I want to talk about in a few seconds, or Raj cannulating. What we're going to do tomorrow during the didactic sessions, during the Q&A sessions, in the relevant topic discussion or sessions, we hope to at least give you an update or show you images, and even better, if we can, show you videos from the cases that we did today that we were not able to show you live. That's our hope, and that's what I hope we can do tomorrow. Dr. Noel, do you want to talk a little bit about your amazing case and what we learned? It was a humbling experience, wasn't it? And I'm hoping that you can go over your algorithm for difficult cannulation and what you were thinking, or what we were all thinking during that case.
No, thank you very much. Yeah, incredibly humbling. But I suppose that's what it's all about, and it's fantastic because that's when the best learning opportunity comes through. So to sort of just give you a bit of background, I think there was ultimately, I think it was done off air, but we will hopefully show it tomorrow. That first cannulation where there was sort of the angulation and orientation of the guide wire, where we initially perceived that to potentially be the pancreatic duct, was actually the common bile duct. And we actually never went into the pancreatic duct once. It's humbling because we had a number of experts there, and we didn't recognize this early on enough. And coming to your algorithm, I think the first thing was that, early on, I was relatively confident that I was in the sort of the 10, 11 o'clock position, and it didn't really make sense that we sort of, or I cannulated the pancreatic duct, but the angulation and orientation was sort of in that direction. And we went on to, as you saw, to do the pre-cut, and time and time again, the cannulation went in that same direction. And I think there was the biggest concern early on is if you sort of looked at the preoperative or the pre-procedural imaging, that presumed pancreatic duct was just slightly too dilated for it to be a pancreatic duct. If the mass was distal to that, sort of in the ampullary area, that makes perfect sense. But the mass was proximal to that on the CT scan, and that duct was 3-4 millimeters, maybe even a little bit more. So that was the first concern that I had early on. And then the second was the lack of side branches, which was pointed out. So that if that was the pancreatic duct, there wasn't side branches. And again, coming back, sort of the thought process is that the orientation and the angulation, this must be the pancreatic duct, but it didn't make sense. The concern of putting, again, normally what one would do is try cannulate the pancreatic duct, presumed pancreatic duct, with a guide wire. Try not to get contrast into it, because once you install contrast, your chance of pancreatitis or post-ERCP pancreatitis goes up. But the stricture was so tight that we weren't able to pass the guide wire. And I think that was the third sort of probably pointer that we were potentially in the right duct, is that if we were in the pancreatic duct and that initial appearance was potentially the cornu of the pancreatic duct where you can get high gump, 9 out of 10 times you can pass that without an issue. And despite sort of probing quite extensively, wasn't not able to pace the pancreatic duct. We we'll go to an algorithm now, but the long story short is we actually got to a position where we almost paced the pancreatic stent in order to reduce it and do a septotomy. And just prior to that, fortunately, with a bit of support, we backed the concept that this was actually the common bile duct, and we under sort of balloon cholangioscopy or balloon occluded cholangioscopy forced a bit of contrast through. And you'll see tomorrow, but the stricture was less than 1 millimeter. And we were able to hydrodilate, get our guide wire across and place the stent successfully. And in hindsight, probably one could have reacted to that a little bit earlier. But again, despite how many experts, we thought we were in the pancreatic duct for a large proportion of it. Yeah.
Yeah, and this is open for discussion. I'd love to know what you all prioritize in your practices to reduce the risk of post-ERCP pancreatitis. And we'll start with you, Alan, what your practice is.
So we give rectal medicine to all the patients unless they have renal failure or liver transplants. Our liver transplant colleagues don't feel comfortable doing it routinely. Everybody else does. The very high-risk procedure, so ampulectomies, for example, we will also give high fluids for them up to 8 hours post and keep them. We don't often keep patients. We'll keep them in the short stay unit and then send them home during the evening if they're doing well. So we don't keep them overnight, but we will give the full protocol of high infusion. With regard to pancreatic stents, you're familiar with the randomized trial published in the Lancet last year, suggesting it was non-inferiority trial, suggesting that for high-risk patients, although it was a negative non-inferiority trial, but it did not rule out superiority of putting a pancreatic stent. And the interpretation was in the very high-risk patients, there may be a summative beneficial effect beyond rectal NSAID to actually put in a pancreatic stent. So based on that, we do put in prophylactic pancreatic stents for patients who are at particularly high risk, such as, again, patients in whom we had very difficult cannulation, patients had previous bouts of pancreatic of pancreatitis, and so on.
Thank you, Sachin. Pretty much the same as Alan said, but I would start with the indication, actually, which we always go back to, is that try to be very careful with the indication for the ERCP, because typically the ones who have the weakest indication are the ones who get the highest complications from ERCP.
Yeah.
Those young females with non-dilated duct and someone like some change in liver functions, and there is a question of there is a stone or no stone. Always remember that we do have EUS, so we can put the EUS scope down first and take a look. If there are no stones, there is no really indication to do an ERCP on them. But then once we embarked on the ERCP, I think it also depends on how the procedure goes, the technicality of the procedure. If we've cannulated the pancreatic duct multiple times, if we had to inject the pancreatic duct, typically we leave a PD stent in there. And then for us, rectal endomycin is a standard for all patients. As I tell our nurses, if they have a rectum, we're going to put a rectal endomycin there. So there is
So wait a minute.
every single patient.
So moment, you're saying that all patients that are getting an ERCP are getting rectal endomycin?
Yes.
Regardless of whether they've had a sphincterotomy done in the past?
Even for repeat ERCP, in my opinion, if you go in the court of law, I do some medical legal work, and on that side, they don't fully understand what we talk about. But if you go in the court of law, this is a very simple, cheap intervention with very, very minimal side effects. And the first question is like, why wouldn't you put that there? I know you would tell them the guidelines say you have to put it only in the high-risk patients, but this is a very simple and cheap intervention. So for us, 1 liter of LR and rectal endomycin is a standard for all ERCPs, whether if it's first time or repeat, high risk or not high risk. Of course, fluids, if there is any cardiac issues, if they have low ejection fraction, that's a different story. But outside that, all of them, they get rectal endomycin and LR.
Colin, any final comments, you and Ryan?
No, I mean, we completely sort of similar to that. I think the only thing is that I have a very low threshold to move on with my algorithm. I think the biggest cause for me, pancreatitis, comes from edema of the pancreas. I mean, edema of the papilla and actually irritating it. So we move across our algorithm far earlier than 5 minutes, 5 attempts, struggling like that, as you saw this morning. Yeah, but that's the only.
And I'm sure we'll get some more time to talk about this tomorrow as well. I'm not sure it's such a cheap intervention to give rectal indomethacin, because you may have seen the recent data on the skyrocketing costs of indomethacin. But you can compound other NSAIDs, which is a really cheap option. So with that, we're going to go to our next live case, which is in room 14.
So this case, a 60-year-old female with a history of Roux-en-Y gastric bypass 2004, pre-bypass weight of 300 pounds, lowest weight down to 145 pounds, who has been regaining weight 2 years after bypass. Patient's trial weight loss medications such as phentermine with no improvement. Liver biopsy demonstrated bridging fibrosis with developing nodularity, so the patient was referred for transoral outlet reduction. Current BMI of the patient is 57 with comorbid conditions of hypertension, I think that's supposed to be obstructive sleep apnea, and MASLD. EGD showed a dilated gastrojejunal anastomosis up to 35 millimeters with sutures seen at the anastomosis. No ulcerations or contraindications to outlet reduction were demonstrated. Here you can see a very substantial dilation of the gastrojejunal anastomosis with some surgical instrumentation at the 12 o'clock position. Dr. Fan, this is Ryan and Sachin, Colin and Alan Barkin here. How are you? Can you hear us?
Hi, yes, I can hear you. Sorry, we're a little bit in a little bit of chaos here. The patient just got sedated and intubated, so we're getting everything ready. But this patient's story is very typical. She had her surgery done a long time ago and has significant weight regain. And we know she has a significant risk factor for it, because if we see her GJ stoma is significantly open. And what we know is that when a GJ stoma starts to get above 2 centimeters, the risk of weight regain becomes significantly higher. We also know that if the gastric pouch starts to elongate closer to 5 to 6 centimeters, that's also another risk factor for weight regain. We always want to do a close examination of the pouch, because the third biggest reason for weight regain is a GG fistula, so a fistula from the pouch to the remnant stomach. And what we see here is the lack of a fistula in general. And so here what we see is some staples. I'm actually going to remove these staples from here because staples themselves in this area can cause an increased risk of ulceration. And what I know is after I do this tour, these staples hopefully won't be accessible. Open, close. And so I want to remove them now, open, before they become an issue later, close.
And Jen, what do you think your overall strategy here? Are you going to try and do running suture around the margin of the gastrojejunectomy? Are you going to try and do some Z-like suturing to reduce the overall size of the aperture? How are you going to attack this dilated gastrojejunectomy anastomosis?
Yeah, so great question. So there is a recent white paper that came out showing that purse string is better than interrupted. But for the last year or so, I've actually gone away from the purse string suture. And can I get the APC ready? The purse string suture, and have gone into a running zipper pattern. And so the running zipper pattern was first introduced by Dr. Bara Mabudaya. And we were waiting for him to publish his technique, which finally came out in Video GIE. But for the last year or so, my colleague and sponsor Ken Chang and I have been doing the zipper pattern. And what we've noticed from the zipper pattern is that patients, the purse string suture is a fantastic suture pattern. However, it's very dependent on how the endoscopist takes each bite. And if I can show you just real quick, when you're doing the purse string suture pattern, you're actually going to rotate your scope completely 180 degrees up to 270 degrees in order to actually get the purse string effect. And what that means though is as you're twisting your scope to that direction, it really is important that you're getting quality bites. And yesterday we taught the fellows that not having quality through and through bites means that these bites can rip. And again, this GJ anastomosis is going to get food and liquids multiple times a day. So what we see is that the suture pattern can break down based on the quality of this person who's doing the suturing. And so we have Bilal here in the room, and he also does this as well. So I welcome him. Any comments in from anyone else? But what uh-oh. And what I typically do now is I'll do a running zipper pattern from the 6 o'clock position, going up and zippering this together to make the diameter only 6 millimeters after. So kind of two ways to do this and to prepare the stoma. One is doing APC around the stomal wall, and the second is doing ESD. Now, typically, I actually favor doing ESD because we're really exposing the submucosa and the MP there, really getting some good bites to go through. However, what we see here, she has no ridge pretty much here. The entire posterior wall of this GJ anastomosis has no ridge whatsoever. So it'll be a little bit more tricky to actually do an ESD around this area enough to get a good suture bite. So for this patient here, we're actually just going to APC around. We're having a little bit of trouble here because every time I APC, my monitors go blank.
That's funny. That's happened at our institution too. Have you guys seen this?
Well, this is the first time I'm in Colorado. You should with me in Minnesota.
It's can't work.
So you brought this with you, is what you're saying. Okay. Yeah. So how often do you end up using the APC technique versus ESD?
I am almost exclusively ESD technique, but her stoma is so wide open. 35 millimeters, as Bilal said, is really wide open. There's really no ridge here to count on. Right. So typically this process is very quick.
Jen, we can't hear Bilal. So if he's making a comment, then he needs to really cozy up with Samit so that we can use his microphone, or give him another headset, please.
So I'm so sorry. This is a little bit slower than usual because I'm dealing with the fact that the screen keeps giving out on me. And the important thing here is to make sure that I'm not taking too much jejunal tissue as I'm coming around, but I really want to make a very big ring. So I want a big engagement ring here of the APC. So this is just my first layer, but when we teach this, we really want almost a centimeter worth of fulguration around the GJ stoma here. And it really helps set us up for success in terms of allowing the tissue to reepithelialize and to scar down.
Well, for someone who doesn't do this procedure, I feel like you're doing this very quickly, Jen. So you're good.
So again, if a patient has a GJ stoma of around 1.5 centimeters in size, we actually typically recommend only doing either APC or ESD because that's enough to scar them down. And remember, we only really want to scar them down to around, we will tighten this to a 6 millimeter size, but once the inflammation dies down, it'll start to open up, so it'll become more of a 8 millimeter to 1 centimeter outlet, and that's great, right? That's around the size that they had before at the time of the gastric bypass.
Jen, I have a quick question for you, Moment here. I don't do this procedure, but would there be any concern from having ulcers at the site of APC? Like those patients without any intervention, they can get anastomotic ulcers. The vascularity in this area is already altered by the surgery. So do you have any concerns, and how often would you see ulcers at the site of APC?
So yeah, that's a great question. We rarely do actually. This area will scar down quite a bit. Typically, we see ulcers at the area of the GJ anastomosis itself, and that's why I removed the staples from before, right? The staples in solvent foreign material can increase the risk of causing an ulceration. But typically, and maybe it's because we actually don't scope patients during the healing process of an APC TORI, but we rarely get complications related to bleeding secondary to where the APC site is. I'm going to have the team kind of open up the overstitch device. And here I'm just going to I'm using the Fuji 2T scope so I can suction out the gas that's there. So we're starting to get it, but as the team opens up, I'm still going to keep burning this area because I really like some injury here. I really want this to scar down as much as possible and be compliant to take my sutures as well as possible. Okay. All right. So this is actually turned out pretty nice. It's around a 1 centimeter ring of APC around to suction down everything, and then we're going to remove. Mm-hmm.
Bilal's question was, do you want to comment on the color of the APC following treatment?
Yeah. So what I want is to really see that brown charring. I really want to see some superficial mucosal damage here. I really want this to help me scar down and to accept the suture material as much as possible. So that's why I want some brown coloring, not just white coloring, just from superficial APC. Yeah, so use 0.3 flow and then 70. Okay, so I'm going to take this out and we're going to put on the device. So I don't know if you guys are still with me, but there's kind of two options here for the overstitch device. One is using the double channel scope, and then the other is
Jen, can you
using...
hold on for a second? We want to see exactly what you're doing. We want to see your hands. We want to see how you're working on getting this set up.
No problem. Can you see me now?
That's great. Yep. Yeah, we can see.
Okay.
We can see you better now. Yep, I like that.
So this is the overstitch device with the 2T scope. There's also the NXT that can be used with a single channel device. I typically use the double channel device because when I'm doing it with my techs, we do it so quickly with the helix that I like the speed of which we're kind of dancing with each other, right? There's almost no communication when I'm doing this with my home institution. So it's really quick when the tech is using the helix as compared to the NXT, which is fantastic, but the operator uses the helix. And so the good thing though is when you're starting out doing suturing, the NXT allows the operator to have full control, right? And the angle of which the NXT sits on the device actually gives you a big bite. And it's really important when you're doing these bariatric procedures that you get full thickness bites. So you'll see here I'm introducing the 2O-proline suture. We're going to do an exchange to get it into onto the needle, and we're pretty much ready to go. So the suture will go into your channel, your big channel on the right. The left channel on your double channel scope will be the acceptor of the helix. I always ask for a jaw thrust here because the device is so big. I've not used an overtube for a while now. But when we talk about this with our fellows, it's so important to introduce the 2T scope with the overstitch device slowly, right? The areas that you can absolutely cause a tear are the upper esophageal sphincter and again in the lower esophageal sphincter. So here went in really nicely. Thank you for the jaw thrust. And whenever we're advancing, we always have the device closed. right? Because when it's open, there's a blind area that increases your diameter of your device by almost another 50%. Okay, so now I'm going to see that this here is my outflow track. This here is my blind limb. So what this suture pattern is, it's a little bit different. You want to make sure that you zipper towards your outflow track here. So I'm going to actually start, this is going to be my 12 o'clock position. This is going to be my 6 o'clock position. So I'm going to use the helix. And the first bite here is actually the hardest. Ideally, if it's acceptable, you want to take your first bite from gastric side to jejunal side. So I'm going to rotate my scope, and this is the hardest part of this technique. I'm going to go right here. Go ahead. 1, 2, 3.
Ryan,
I'm going to pull this towards me.
We can skip the stent fix.
Come back. All the way back.
Have them wait on
Go ahead. 2, 3. And I'm going to take my first bite from gastric to jejunal side. Okay, go ahead. And the reason for that is when I cinch, I want the cinch to lie nicely against the gastric side here. So now I just took the 6 o'clock position is right where it's right here to the right of the first bite. Now I'm going to go around 5 o'clock position.
Ready to go,
and
I'll
this
let you know
is
when we'll go to 16.
And this is the first bite of the zipper pattern. So 5 o'clock position. Now I'm going to go around 7 to 8 o'clock here.
Jen, once you get into this rhythm and you've shown the few basic steps for this procedure, we'd like to go to 16 to see Dr. Tucker. But you let us know when we can go.
So let me take 2 more, this bite and the next bite, and you'll kind of start to see the zipper pattern start. So if you can see, the bottom is already kind of coming together. Yeah, so I use helix for the first bite to really help me kind of get through and get full thickness. So you can see here, and I'm just gonna pull the suture a little bit, that this is already gonna kind of start to come together. So I'm gonna zipper and keep zippering up. The stoma is so big that I might have to cinch after a couple bites and do another zipper. This is one of the bigger stomas that I've seen, and I'm not confident that one single suture can accommodate the stress of how big this stoma is. And so with that, maybe you can go over to the other room, and then we can touch base after our first zipper pattern has
Sounds
finished.
great. Jen, you make it look so easy. Thank you so much. Let's go to the next case.
It's a 53-year-old male, past medical history, Roux-en-Y gastric bypass in 2001, who presented with right upper quadrant pain, found to have emphysematous cholecystitis, status post-laparoscopic cholecystectomy, with drain placement, complicated by a bile leak and a gangrenous gallbladder. Patient developed sepsis post-operatively, was transferred here for ERCP of bile leak management. Initially, an attempted balloon enteroscopy assisted ERCP was performed but was unsuccessful. Thus, an EDGE procedure stage 1 was performed on 9/9. Patient has continued to have increased bilious JP drain output. The plan for stage 2 EDGE and ERCP today for management of the bile leak. So on the upper left corner panel, you can see, for those of you that were here yesterday, the classic or semi-classic sand dollar sign of the excluded stomach under endoscopic ultrasound. Remembering that we talked about that sand dollar sign represents the gastric antrum. So maybe not an ideal place to place the lumen opposing metal stent. And then the lower middle panel shows the excluded stomach filled with fluid instilled by an EUS FNA needle. And then placement of lumen opposing metal stent into the excluded stomach, which you see on fluoroscopy to the right upper corner. Sham, we're here with you. You want to give us an update of where things stand and what we're going to do here?
Yeah, how are you guys? And I have the great hero over my shoulder here on the left, the outstanding Amy, who is a nurse tech extraordinaire. And this case was actually done by Blake as his first case as an attending earlier this week. And I got to tell you, he did a fantastic job. I mean, he put this stent pretty much almost exactly where you want it. We went through it already, and it's, you know, in the body portion of the excluded stomach, which will give us a nice runway to the pylorus. Now, being that it's only a few days old, we've opted to try and secure this stent. And I think there's two ways you can do this. The first is to use the overstitch device, and that works very well. And, you know, we do that a lot at WVU. We actually did a study on using the overstitch to maintain the fully covered esophageal stents for esophageal cancer or various other stent indications. And what we found was that it reduced migration rates from 58% in the unsutured arm. It was a randomized controlled trial we did to 16%. So, you know, I think, you know, just applying that thought process here, you know, certainly overstitch would work very well. Now, the other option that we have is using the stent fix. The stent fix is by Avesco, and we've actually attached that to the cap of to the tip of our scope here. We thought that would be a good demonstration to show, since you're seeing some very nice suturing from Jen in the room next door, and just looking at this stent, kind of thinking about where we'd want to place the stent fix device. Essentially, this is a modified OTSC clip, and the way it works is basically you come into the stent and you want to suction in part of the stent and part of the stomach wall here, and we would suction it in and then deploy in order to get both together. And so I feel like I'm going to get a very nice bite here on the right hand side. We could deploy one, we could deploy two, one on the right, one on the left, or we can just go simply on the left hand side. And here you can see how we can line it up, and then again suction it in. Oops, not like that. That's not how we want to do it. But here on this side. So here you can see it seems just a little more superficial. So I'm favoring a bit more the right side because I feel like I can get a nice full thickness bite. Panel, any other thoughts from
I
your end?
agree, Sham, the right side looks much better than the left.
Yeah, I agree.
And Sham, are you thinking of putting one or two?
Yeah, so I think that both options are there. You know, I feel as if the right side is actually going to be the best side to secure this because, you know, looking through the stomach here, the pylorus is down to the right, and so the drag is really going to be on this right side. So I think securing it on the right side probably will be enough. Plus, I'll get a nice full thickness kind of bite of this fold. So I'm sensing that I'm probably okay doing one, but if you guys would like me to place a second one, I certainly can, and then bring you back for the ERCP portion.
Sham, this is Momin here. It's very nice case. Just I don't want to be the devil's advocate here, but I noticed on the left side that you can see the stent better when you suction. Like on this side, would you have any concern that when you suction and the mucosa just comes in and you're not seeing the stent, that you might be missing the stent before you deploy? Like, can you walk us on how you, like, the thought process goes when you're deploying? Because the mucosa will suction in easily, definitely, compared to the stent itself.
That's a good point, Moment. And I think here I'm seeing the stent within the cap, so I feel very comfortable. I am getting more gastric tissue, but I actually kind of like that in this case because, again, I want to make sure that my stent is holding on to more tissue. On the other side, I felt as if I wasn't getting as much gastric tissue. So that to me was a bit concerning. And here you can see I've got
Sham, I'm sorry to interrupt you. We've got 15 minutes left for live demonstration, so I want to maximize our time. So if you can go ahead and deploy this.
Yeah. Boom. So there it is deployed. And now we've got a nice bite. You can
Yeah,
see we've
nice
got
bite.
stent
looks
in there,
beautiful.
okay?
Very
So
nicely
I
done.
feel good about that, guys. I'm gonna go straight to ERCP. We're gonna capture that image, and I'll bring you back going through this stent, and hopefully you'll see us cannulate before you leave.
Fantastic. Thank you, Sham. That was fantastic demonstration. All right, let's go back to Jen's room, Dr. Fan.
It's done.
Dr. Fan, you're live. Can you hear us? Jen, can you hear us? Yep. Okay. We can't hear you as yet. Jen, hold on for a second. We can't hear you.
They can't hear us.
Yep. Now we can hear you.
Now we can. Okay. So you
Okay.
came back
Thank you.
just in time. So I just finished the second zipper pattern. I'm putting down a balloon, and because I've angled my zipper, I know that when I'm putting it in, I have no resistance here. I'm putting it into that efferent limb of that jejunum there, not into the blind. I'm going to have her go to 6 millimeters, and then I'm going to have the cinch come over here. So the dilation balloon, good, perfect, and you can just drop that. So the dilation balloon goes into this second ancillary channel here, the same channel that I put the helix in. And you're going to see that after the 2 zippers and after we cinch, this outlet that was previously 35 millimeters will now be only 6 millimeters in size.
I hope you guys can already appreciate when you came back how small this opening looks just in those 5 minutes of suturing. Is very impressive to stand here and watch that.
That's okay. Yeah, so it's a little tricky here. So sometimes this orange part of the cinch can break.
She got it.
Okay. So I always tell my fellows that this device here made how this device can have tricky steps to it really makes you have to understand how to use this device into its entirety. It's such a great ability to be able to suture, but things can always kind of happen. There's a lot of steps here. So here my cinch is coming out, and ready? Yep, cinch. Go, go, go. Good. Okay, balloon down. Okay, so we can see here that in how many minutes that was, the outlet is over here. Once I take this out, I'm not going to go through with the 2T scope and the overstitch device over it, but the outlet is now 6 millimeters and small, kind of right here in this angle here. It's important now that we never leave this without reinforcing sutures, right? This is a lot of stress to put on these 2 sutures that have now zippered closed the stoma. We can also tell that her pouch itself is really quite small. So there's no need to do a pouch reduction. Naturally, I'll take another suture. Naturally, the pouch will reduce a little bit with the next reinforcing sutures. But innately, we don't want to reduce this pouch too much or else she'll get significant reflux and regurgitation of food.
Do you make that decision based on the measurement beforehand or your appearance after?
To reinforce or to pouch reduce?
Applicate, yeah.
Yeah, so the pouch reduction, there's always a little bit of a pouch reduction that happens naturally with the TOR.
Yeah.
But if anything is above 4 centimeters in size, I will typically pouch reduce. I want to get them back to the initial size that they had right after the gastric bypass. I'll take the...
Jen, do you have any final comments you want to make? We're ready to go to the other room. Sham is ready to cannulate.
Nope. Go ahead.
Fantastic. This was an amazing demonstration. Thank you so much. Hey, Sham, can you hear me?
Yes.
All right. Looks like you got through the lambs and you're ready to cannulate. Was it tough to go through?
No.
Fantastic. Well,
Yeah,
you
yeah.
may,
If you see
you're
the
a master
X-ray,
endoscopist, man.
no, man. But we got a great team, so that's what made it possible. And like I said, Blake put the stent in a great position, so it made it very easy. But if you see our X-ray, you can see the stent right there around the scope. Can you guys appreciate that? Right around the mid portion of the scope there.
Yeah, it's difficult to see from here, Sham.
Yeah.
But we're ready to see you cannulate.
Okay, great. So we're just going to try and engage the ampulla here. And did we give some glucagon? Okay, wonderful. So just flex the catheter for me a little, please. Yeah, yeah, flex a little more. Good, good. And let's go ahead and try the wire, please. Flex it a little more, please. Yeah, yeah, good. Uh, so here I'm just trying to straighten out my access to the CBD, and I'm not liking it.
So
Hero doesn't
more
like
upper
it.
region because
Can
Pardon?
you elaborate on that, Hero?
Yeah. There you go.
Okay,
So
okay.
let's try the wire a little, please.
Mm.
Yeah, yeah. Just jiggle it and see if you can get it to go. No, no. No, just keep trying. Let's flex it a little bit more for me, please. Yeah, good.
Yeah, that looks better.
Try there. Yeah.
Mm.
And let's try and
How about this?
relax the catheter. Yeah. Yeah, yeah. Relax a little bit. And try the
I
wire
think we're
now.
done with 14
Maybe
and
good.
let's wrap it
Yeah.
up really
No?
quickly here. We've got
Feels like
less
we're
than
in
10
somewhere.
minutes left for cannulation
And so
tracheotomy
just gently,
placement. So I
I'm
think we're done
turning
with
my
14.
outside control counterclockwise and rotating my wrist clockwise. I feel like
And
I've
we've
gotten in
lost
somewhere, but
the feed
it's not very
on the
clear.
front
Can you strip the
screen
wire
here.
down to me, please? Yeah.
Oh, self-control.
Yeah. Yes.
No,
So
not for
I'm
you,
going to try
Sean.
a little bit of self-control here, and then there we see into somewhere. There we go. And that looks
Oh,
like the
PD.
PD. So we'll go ahead and leave a wire in the PD.
Can we get a larger image on the fluoroscopy image, please?
Yeah. Good. And let me just have an 025 Visi, please. And so I'm just going to leave that wire in to just help stabilize the ampulla, and then we'll go off of that wire into the CBD. Thoughts about the double wire technique? I know we talked a little bit about it earlier when Colin was doing that sweat full case. But to me, I like having the wire in place. I think it gives you an opportunity to stabilize the ampulla that you can bounce off of it to go into the bile duct, of course. Any other thoughts about double wire technique from the panel there?
No, I think that's exactly what I would have done too, Sham. You've got a wire in the pancreatic duct, and I would have gone with the double wire technique as well.
Yeah. You know, in these cases of the edge also, you know, part of this is things don't line up exactly as normal, though you can see we've got a pretty good and decent position here with the ampulla with respect to our scope. But oftentimes it can be, you know, a little bit more challenging in that regard. Are we stripping out? Yeah. Do you want to just backload it? Yeah. Yeah. There you go.
Sham,
So,
while you're getting the next wire in, can you tell us what devices you're using and what your next
yeah.
steps are?
Yeah, so, you know, this is a patient with a bile leak, as you guys already heard. So, you know, we've used an 035 Jaguar. Typically, this is kind of my workhorse device where I go with a 44 and a 35 wire, Dream Tome typically. If for any reason I don't have success with that, then I'll switch to an 025 Visi or a 39 catheter with the, and I prefer the taper tip catheters for cannulation. I know some individuals prefer the dome tip. I think there's advantages and disadvantages to each. You know, the taper tip type catheters have, I think, a little bit more ability for, you know what, it's too short of an exchange. Let's bring it all the way back if you don't mind. Yeah. So the taper, you know, the dome tip catheters cause a little bit less trauma. And so sometimes, you know, for the fellows in the room, if they're using the dome tip, it can be a little less, a little more, the ampulla, it can be a little more forgiving for the ampulla. when it comes to the taper tip, I think they can be allow for a little more efficiency, but beating around the papilla too much can certainly lead to a lot of swelling very quickly. So those are the kind of the advantages or disadvantages. Any other thoughts on that, Hiro?
Sham,
Yeah. So
I'm sorry. You're going to give me grief for this again, and we can talk about this when we have dinner tonight. You have 6 minutes of live fluoro, so we want you to get into the bile duct, do a sphincterotomy, tell us if there's a leak or not.
Yes,
Yeah.
sir.
Yeah. So the
No rush there. We're
Sham,
not
No rush,
stressing
yeah.
you or
use
No
anything.
pressure, no
025 guide
pressure.
wire
In an
or
edge
035,
case.
That's right, eh?
standard procedure.
Can you strip the wire down, please?
Mm.
Yeah, good. Flex the catheter, please.
Mm.
Yeah.
035? Do you use?
We have an 035 in place. Now I'm using the 025 Visi.
Mm.
Flex, please.
Mm.
Yeah, a little bit more. Good.
Oh, maybe a good
Good,
direction.
good. I
That
like
looks
that.
great.
Mm.
So now we got a little bit better. Was that going in the same PD?
Same route.
Same PD,
Same
same
route.
PD. Okay, not good. Go ahead and
Mm.
flex more, please. Yeah.
Yeah, put it on the other side.
Same route again. Okay. Flex a little bit more for me, please.
I get it on the other side.
Good.
Yeah.
That looks better.
Ah,
Yeah,
very
that
good.
direction looks different.
Yeah, yeah.
Mm.
Good.
Maybe around
So, and this is typical for a bile leak where things are just a bit
where the
tighter.
drain is.
Mm.
So it looks like we're into the bile duct, though I want to get my wire into a little bit better position here. There we go. And, you know, this wire just stripped a little bit, so I'm going to try and send the whole catheter up to make sure I can get it into a decent position. It's not flowing as nicely because it's just getting caught up a little bit on the catheter. There we go.
Mm.
All right,
That's
so
really
now we
nice.
got into a better position. Capture an image. And so I hope that was, you all can understand how we did the double wire technique there. You know, the first wire allowed us to gain stability. And then I hope you were able to appreciate that what we did was just try to anchor the tip of the catheter into the ampulla and flex the catheter up in order to gain access. And, you know, looking at that 11 o'clock position and then flexing up a little bit more allowed us to use that wire guided technique with gentle just manipulation of the wire until I could feel it go right into the bile duct there. So now we're going to get a cholangiogram. Yeah.
Oh, contrast.
Yes. Go ahead and inject. So fairly small duct. We're seeing the interhepatics fill. I have not seen leak yet, but that might be, yeah, right there, right by the drain. It looks like it's a leak from the cystic duct remnant.
Oh, yeah.
Yeah.
Is there any way someone can magnify the fluoroscopy image?
Yeah. Can we magnify the fluoro image for me, please?
Although I can see the leak you're talking about, Sham.
Yes. So let's see, is it magnified? There we go.
Yes.
How's that?
Yep, we can appreciate the leak.
Yeah, you can appreciate that now? Okay, so now we're not going to inject any more because we certainly don't want to continue to put the patient at risk for any biliary peritonitis. The one thing with using, you know, an 025 wire with this catheter is that it can stick into the catheter, so you just kind of have to railroad it back and forth to make sure you don't lose your wire. But now we're going to do a sphincterotomy. And so what I like to do in my sphincterotomies, I like to cut with the tip of the wire and minimize contact with the scope, of course. So I'm going to have her flex the catheter. And
Sham, hold on for a second. Can we magnify the endo image, please?
Yes. Let me know when you have it there, Sachin.
Yeah, we can actually see this. You can proceed, Sham.
Beautiful. Okay. So
Thank
we'll do
you.
our sphincter. Yeah, good. Just make sure my wire's in good plot. Good. So we're going to just do our sphincterotomy, and I'm going to use the scope and a combination of my elevator to orient my sphincterotomy. And as you can see, I'm just pulling back a little bit with my scope and gently moving to the left there to just get my sphincterotomy. I'm getting a little bit more so in the 1 o'clock position, not where I want it. So I want to try and pull it back with some body language.
So for the trainees in the audience, what he's doing where he's creating tension with the scope is excellent. So you don't have to use the big wheel, or you don't have to use the elevator to create tension on the cutting wire. If you just give a little bit of gentle tension by pulling back on the scope, you create plenty of tissue touching your cutting wire.
So, I think that should be a good size sphincterotomy for our stent placement. And I think I'm going to move forward here with just a 10-9 CBD stent. That should be good enough to seal this off. And unless anyone feels that we should be putting a fully covered metal stent in, I don't necessarily feel that way at all. I think that
I
this should
agree.
work. A 10-9 CBD plastic should work out just fine.
And Sham, what stent are you going to place in the pancreatic duct?
Sorry. Do you keep the pancreatic guide wire for the pancreatic stent placement?
Yes,
do
good
you
question.
prefer?
Good
Yeah.
question. Good question. So in this case, I will put a PD stent in to minimize any risk of posterior RCP pancreatitis. So in this case, we put an 035 Jaguar in. So we can push a 4x9 without a retention flange, or we can put a 5x3. I might just feel good about a 5x3 in this case. It'll fit nicely over the Jaguar. You asked me what stent, Sachin.
Yes.
I prefer a 10x9. I do like the Cotton Leong stents. I know that's not a fan favorite here at University of Colorado. So what is your preference, I guess, in this situation? Would you use a Jolin? I just worry a little bit about no retention flange, but Raj says that it's not an issue, and Bilal says it's not an issue. I'm guessing you're going to say the same.
Yeah. I think, our go-to stent is the Advantix stent here. So I think 10.7 or 10.9 would be perfectly fine. And are you planning on putting like a 5.3 or a 5.5 PD stent?
Correct. I was gonna do a 5.3 PD stent with a pigtail and a 10.9 CBD stent. Yeah. So I would go with the 5.3 first, and then we'll go with the 10.9.
That's terrific. Sham, what an amazing demonstration. Congratulations on
Thank you.
completing this
Congratulations
case.
to you on an
And
awesome course.
and Sham, you finished it in 6 minutes. So thank you. Right,
Is
really
that okay?
appreciate it.
Sorry.
A round of applause for all our endoscopists. With that, we come to an end to our first day of the main course. I just want to acknowledge so many individuals. What you saw all day today took us months to plan, and it required the dedication from our nursing staff, who've obviously worked tirelessly in planning and executing what you saw on screen today. I want to acknowledge the Proximie team who made this live transmission possible, our partners at UC Health for supporting this course, Christy Click, of course, without whom this course would not be possible, and of course to all our excellent faculty members who obviously have moderated cases all day and performed these live endoscopy cases as well. So we look forward to seeing you tomorrow bright and early for an exciting day of didactic sessions. And we actually will have some lively debates as well, where we'll challenge each other on some of the dogmas in endoscopy. So thank you again for being here, and we look forward to seeing you tomorrow. Thank you.